today's meeting. Abigail Marshall-Cutting is my name. I'm one of the councillors in Leeds City Council, and I'm also the chair for Adult Health and Active Lifestyle Scrutiny Board, which you're all here for today. So very warm welcome. I can also see students from Leeds Trinity University and their lecturer. So thank you very much for joining us. Are they undergraduates or postgraduate students? You've got both. Excellent. Are you all happy there? Yeah, good stuff. Okay. So just to let you all know that this meeting is being webcast on the council's website so that any interested members of the public or other stakeholders who are unable to join or observe in person can actually observe the meeting remotely. The meeting recording will also be available on the council's website after today's meeting. So first of all, I would only be inviting board members to introduce themselves. We've got a very packed agenda this afternoon, so others will be introducing themselves when it comes to your agenda, if that's okay. So for now, it will just be board members introducing themselves. And I'll start with you, Councillor.
Thank you, Chair. Councillor Eleanor Thompson, representing Guiseley and Rawdon Ward.
John Beale, I chair Health Watch Leeds and I'm a co-opted member of this board.
Councillor Mohammed Iqbal for Hunslet and Riverside Ward.
Luke Farley, Labour Councillor for Bermondsey and Richmond Hill.
Councillor Karen Renshaw, Martin Robin Hood, substituting for Eileen Taylor from Chapel Allerton.
Councillor Sharon Burt, Middleton Park Ward.
That's it. Councillor Winkage, Morley South.
Councillor Conrad Hartbrook, Rothwell.
And Councillor Norma Harrington, Wetherby Ward.
Good afternoon, I'm Councillor Caroline Anderson. I represent Adel and Wharfdale Ward.
Good afternoon. Angela Brogden, Principal Scrutiny Advisor.
Good afternoon, Toby Russell, Clerk to the Scrutiny Board.
Thank you very much, members. I will now ask Toby to run through agenda items 1 to 5 for us.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item number 2, there's no exempt information that would require the exclusion of the press or the public. Under agenda item number 3, there are no formal late items noted. Under agenda item number 4, can I ask members to declare any interest they may have?
Chair, for the sake of completeness, I am a member of the British Dental Association, although I have no financial interests apart from the very large subscription they charge me.
Thank you, Dr. Beale. Noted.
Yeah, thank you. And under agenda item number 5, apologies for absence have been received from Councillor Taylor, and we have Councillor Renshaw as a substitute. Thank you, Chair.
Thank you very much, Councillor, and thank you, Councillor Renshaw, for subbing for Councillor Taylor, who's recovering from an eye operation. Okay, we're going straight to agenda item number 7. Agenda item number 6, minutes of the last meeting, 18th of October. That's all in your agenda pack. Any issues arising from that? Anyone? Can we adopt and accept that as a true copy and all the information on there is correct? Excellent. Okay, right. Agenda item number 7, you can tell them couldn't wait to get to that. We have been waiting for a while now. The last time we had a meeting on that was in March. And I would like to use this opportunity to say a huge thank you to our principal scrutiny advisors who have made this meeting and this agenda possible. Stephen Cotney, even though he's not here, I know how much work he put in trying to liaise with lots of you in the dental industry in making this meeting happen. And obviously Angela Brogden as well, who has, seen it through, and all of you are here today. So I want to use this opportunity to say thank you very much for attending, and we would be very, very keen to go through this agenda with everything inside of us this afternoon. So dentistry has been a very long-standing area of interest and importance to this particular scrutiny board. Earlier this year, the board had engaged with the dental commissioners, providers, and patients themselves to discuss and review access to local NHS dental services, which has resulted in the board agreeing a number of recommended actions during its March meeting earlier this year. A summary note of the findings and recommendations that had stemmed from the board's work in March can be found today within your agenda pack, and that's on page 17. Huge thanks to all the members who attended that meeting in March. I think the only member that's not here, that's still not on this board at this moment in time, is Councillor Dowson, but all the others are still here. So thank you very much for that. The purpose of today's meeting is to consider the current situation, again, in terms of access to NHS dental services and review what progress has been made since we met last in March, including responses to the scrutiny board's earlier recommendations. The board is aware that there have been specific issues raised regarding access to orthodontic services for children, and so the intention is to allocate time during this meeting to have a more focused discussion around orthodontics. At today's meeting, we are very pleased to welcome a wide range of contributors who are able to represent the view of commissioners, providers, and patients in this very important area of our health provision. Everyone will be given the opportunity to speak, and due to the large number of people present today, I intend to invite individuals to formally introduce themselves at the point at which they have been invited to speak, like I said earlier. So to help manage the discussion in a structured way, my intention is to firstly invite representatives from NHS England and the West Yorkshire ICB to introduce themselves and to briefly introduce their briefing paper, which starts on page 27 of your pack. And while this paper does pick up the issue of orthodontics, I would ask that this be picked up a bit later in the meeting, as indicated earlier. Moving on from the commissioning perspective, I will then invite representatives from the Leeds Community Healthcare Trust and the Leeds Dental Institute to introduce themselves and to give a brief overview of the current position from their provider perspective. I will then invite the chairs of the Leeds Dental Network and Leeds Dental Committee to introduce themselves and to give a brief overview of key issues being raised from the perspective of dental practitioners. I'm sure you can tell that there are just so many different parts of dental, but whatever it is, they're all dental. Okay, so we will deal with all of you individually today and looking forward to hearing from you. We will then hear from representatives of Health Watch Leeds in terms of understanding issues currently being raised with them from a public and patient perspective, which is really, really very important for us. Reflecting on the information we have been given from all the perspectives, I will then open it up to questions from board members. It is important to acknowledge that we also have colleagues here from public health who will be briefing the board on the current position in relation to water fluoridation, and there will be time allocated towards the end of this agenda item to consider this specific matter as well. So I will now invite Emma and Ian to introduce themselves and briefly introduce their briefing paper. So over to you.
Good afternoon, Chair. Good afternoon, colleagues. My name's Emma Wilson. I am Head of Co-Commissioning for Yorkshire and the Humber. So that means that dental commissioning is part of my portfolio and my responsibilities.
Hi everyone, my name's Ian Holmes. I'm Director of Strategy and Partnerships at the West Yorkshire Integrated Care Board. And the expectation is that the Integrated Care Board will take on commissioning responsibility for these services from next April.
So if I could just talk you through the paper that we've submitted, which I hope gives you an update where we are in relation to commissioning of services and the challenges that we have faced. Also does give some understanding of some of the national reforms that will help to ease the challenges of access to dentistry, and also talks about those things that we have done locally to do the same. There were two specific but there were some others, but specific issues that were picked up with colleagues in March. One was about information for patients and how they know what services are available to them. And the second was around the oral health needs assessment. So I was going to focus on those two things to start. And of course, I can answer questions or address issues in the other areas. The paper gives some reference to some of the national reforms that will be happening in dentistry. Some of the challenges that we face in dentistry are to do with the national contract and the limitations of payment and ability to deliver services. And there is some phase one work which will help to address some of those. The key component for that is in relation to information for patients. It is currently not a mandated expectation that providers will, or the dental practices, will keep any of their information up to date. That's generally websites, etc. The new reforms will ask them to do so and expect us as commissioners to make sure that that does happen for our providers. So that's something that came into force on the 1st of October, and we are working with our providers to make sure that the information is updated and correct. Any services that we go on to procure do have that expectation in them. So we can therefore use the contract to be able to do that. In fairness, most of our providers are working with us quite positively to make sure that that does happen. The second point that was raised through our discussions in March was around the production of an oral health needs assessment, which we have now completed. We have a needs assessment for West Yorkshire, and that does indicate areas of greatest need and how we might apply our resources and our support to make sure that we address those. We've gone one step further in Yorkshire and the Humber, and we've started to do some place-based work to help us understand specifically for Leeds, and we're doing the same for the other areas of West Yorkshire, that will identify for us where, when we do have resources and we have our challenges, we can target our resources as effectively as possible. And we've outlined some of the findings of that. The challenges of access to dentistry do continue. Many of those challenges are to do with workforce, and I know my colleagues will explain some of the challenges of being able to recruit workforce, but that's only one of them. Making sure that we do put our resources into the right parts of the system is a second, and that's something that we are doing with some funding that we have this year only, to help practices to put on some additional activity, to put on some additional appointments and sessions for patients, both those that need to be seen urgently, but also the next, I think, biggest challenge for us is for patients to find a regular dentist. Finding a regular dentist, a dentist who will accept patients and give them long-term care, is something that we know has been a real challenge for us. And again, our colleagues in the dental world can explain the challenges of that. But funding that we're putting in this year will hopefully go on to address some of that.
Thank you very much. Would Ian like to say anything or?
Yes, thanks, Councillor. So as I mentioned, the expectation is that the West Yorkshire Integrated Care Board will take on commissioning responsibility of these services from next April. This is consistent with the direction of travel of the Health and Social Care Act, where the intention is to bring together budgets at system level so that partners in the system can work together and join up those services. We discussed this at the board of the Integrated Care Board last week, so the papers and the recording of that are available online. I think there was two aspects to the discussion that we had. The first one was, are we doing the appropriate due diligence work? Are we confident in terms of safe transfer of those services from NHS England to the Integrated Care Board? And then the second aspect of it was, do we have a good understanding of the service challenges, the service pressures, and have a plan to respond to those service challenges and service pressures? In terms of the former issue, I think we've identified three key risks, I suppose, in transferring the services across to the ICB. The first one is around staffing and the teams. We know that NHS England are going through quite a significant change programme at the minute, and we need to be confident and assured that the teams will transfer to the ICBs to be able to do the work with us, and that we don't lose that capacity and expertise. The second one is some specifics around how complaints functions will be handled in the future and clarity around the process for that. And then the third one, and possibly the most material one, is around transfer of funding to ensure that there's sufficient funding transferred from NHS England to the ICB so we can commission a service to a level that we are satisfied with. So that's the work that we're doing around sort of almost the due diligence process. I think the second part of it is that do we have a plan to address the challenges that we've got, and are we clear on what those service challenges are? And as Emma's alluded to, I think the challenges are significant challenges in access, significant inequalities issues relating to those access challenges. They're due to long-standing issues that I'm sure you all understand around workforce and inflexibilities in the national contract. But we're really clear that we want to have a plan to do whatever we can as quickly as we can from April around that. And there's 4 or 5 aspects to that. So the first one is really understanding need, understanding the hotspots and areas where people aren't getting a service that we would like them to be getting, and what we can do to address that. The second one is really maximising flexibilities with the contract, recognising that it is a national contract and there are limitations there, to focus on those areas. The third one, and this is probably what the biggest opportunity we've got as an ICB, is how we bring the oral health and dental conversation to the work that we're doing around integrated neighbourhoods. So if we're looking to bring together GPs with community health services, with social care, with other partners, what's the sort of the contribution to the dental response that we need through those arrangements? I thought it was really helpful in your paper that you talked about the role of GPs in dental services in future, and I think there's a wider conversation there around the role of integrated teams to take a more proactive and preventative approach. And I think the fourth one is the work that we can collectively do to influence upwards. I think as ICBs taking these services on at these times, we've actually got quite a strong voice in terms of what we think we need different, what we think we need to be different in taking on these services. So how do we influence national policy so that we can get some of the changes that we know are needed? And it'd be really good to get thoughts and views from around the table on that today. So that was it. I guess the sort of the overarching message is that things aren't going to change massively from the 1st of April. These are a set of long-standing challenges, but as an ICB, we're really committed to this agenda. We're really committed to understanding what we can do and really exploring the art of the possible so that we can make improvements for people in Leeds and West Yorkshire. I guess just to say finally that following the conversation in the board last week, we agreed sort of 3 tests really for the board in taking on these services. The first one is around full transfer of the NHS England team into the ICBs to be able to do the work. The second one is confidence around the money. Is there going to be sufficient money coming from NHS England to the ICBs to be able to commission these services to a standard that we're happy with? And the third one is clarity around flexibility, the contractual flexibilities that we might need and we might want to apply so that we can tackle some of the issues that you've heard about from Healthwatch and other colleagues. So it's a work in progress. Like I say, we're working hard to be prepared for next April, but that's a bit of a summary of where we've got to in our conversations.
Thank you very much, Ian, and that's great to know. I'll just remind members that any questions that you have for any of them, if you just write them down and write down who you would need to be asking in particular, that would be very helpful when we get to members' input. You're welcome, Councillor Venner. Thank you for joining us. Great to see you. Okay, I would now call on Sam to speak to us now.
Thank
Sam
you.
Prince?
I'm Sam Prince. I'm Director of Operations at Leeds Community Healthcare. So Leeds Community Healthcare offers a very small but important dental service, and that's for people who can't access general dental practice. So people who have a learning disability or a physical disability, people who are dental phobic, and we also provide a service for children who are looked after. It's very small. We have a caseload of around 4,000 patients. Last time I was here, I talked about the access that was available for our different categories of patients, and I think there's some small improvements in that. In terms of patients that need immediate care, so they have pain or swelling, they're seen within 5 days, and sometimes the same day if that's needed. We also have a number of patients that are already in treatment and they're all being seen now. So the people that had their treatment paused during the pandemic are all in the process of treatment now. And we also have people who are to be recalled. So that might be after 6 months of treatment, 12 months, 18 months, whatever that is, whatever's indicated. And when I was here last time, 48% of the people on that list were delayed in getting their recall. That's improved now. There's still lots of work to do, but only 33% of people are waiting for their recall. So I completely accept that's not where we want to be, but I do feel that the service is making some progress with that. In terms of people waiting for routine treatment, we have around 200 adults waiting for routine treatment now and around 380 children. Most assessments take place now within 16 weeks, which is good. Again, we can improve on that, but I'm comfortable that we're still seeing improvement in that waiting time. We have a specific risk around specialist paediatric dentistry, and we have been unable to recruit to the post. So we have a fast track into the Leeds Dental Institute for children that need general anaesthetic, but that's not where we want to be. And I look forward to new commissioning arrangements, which will hopefully mean that we have a West Yorkshire service rather than a service at place, because I think that together we can provide a much better service. We've also seen a little bit of an increase in referrals to paediatric dentistry, and we think again that may well be because general dentistry are feeling they can't manage some of the children that they see, and so we've seen an increase there. So my summary would be that we're not where we want to be, but we have seen some slight improvement since I came in March. Thank you.
Thank you very much, Sam. Appreciate it. Okay, I would now call on Richard to introduce himself and give us a brief update from the perspective of the Leeds Dental Institute. Over to you, Richard.
Thank you, Councillor. So my name is Richard Ejikam-Sachi. I'm General Manager for the Leeds Dental Institute, which is part of Leeds Teaching Hospitals Trust. In terms of the position at the Leeds Dental Institute, so from the meeting held in February till now, originally we were focusing on our recovery, but that's now well underway. In terms of actually reviewing our capacity, we've done a huge amount of work now about improving our utilisation. So focusing on really the basics and getting them right. So making sure we're making best use of the capacity that we have, because recognising there's a lot of patients who've been waiting a very, very long time. In terms of our long waiters, so originally we were reporting on those waiting over 2 years. We've now been able to clear those patients now. So they've all been treated in good time by the end of March. So that's now happened. We're now focusing on patients waiting 1.5 years for their procedures. So with those, we're now estimating by the end of March 2023, we would have seen all our patients waiting 1.5 years and then making really, really good progress on to moving towards patients waiting 1 year. So this has now been all the good work that's now been put in place in terms of governance, assurance, quality improvement, have helped them to improve and really streamline those processes to make sure our patients can be seen in a more timely way. Outside of that, so focusing on our good recovery and now reducing waiting list size, we also need to focus on our dental nurse recruitment, because that continues to be a challenge and it is a risk to our recovery. So recognising this is more of a national picture in terms of the numbers of dental nurses actually coming through and if you like the year-on-year attrition in terms of actually training. So the pipeline of dental nursing coming through is a risk. So we are trying to do some novel things within the Dental Institute about how we can make sure that we get that pipeline through, how we can support those staff to obviously stay within the service, upskill them, and obviously contribute to overall service. But it's just recognising that I think something differently has to be done. But within the Dental Institute, we are obviously looking at what else we can do to help support those members of staff. Other than that, I've always said the messages, and we are working very closely with our community partners, but it's about making sure these patients are treated as close to home as possible. Recognising the Dental Institute can be quite an intimidating atmosphere for a lot of patients who are coming through. So working through those pathways, working with our community partners and commissioners, etc., to make sure the services are robust enough, set up, and making sure these patients can be treated as close to home as possible. And if they need a specialist as tertiary level care, that we are always there and available to treat them. So that's it. Thank you.
Thank you very much, Richard. Appreciate it. And I'm sure we're going to have questions for yourselves shortly. Okay, I would now invite Jane Moore to introduce herself and give us a brief overview on the key issues being raised by the Leeds Dental Network briefly. So over to you, Jane. Thank you.
Thank you, Chair. Jane Moore. I'm the West Yorkshire LDN Chair, the Local Dental Network Chair. I am actually a practicing dentist as well. I work in a general dental practice in Leeds. I work for NHS England. I work as part of the commissioning team to try and improve services for patients. And I also work with all our stakeholders. So I work with Richard at the LDI, I work with Sam and her colleagues, part of the CDS. Manaf is a fellow general dental practitioner who is chair of the LDC. So I work with our LDC colleagues as well. And obviously with Emma as part of the commissioning team. I have particular clinical responsibilities for urgent care and orthodontics. And going forward, we'll be working with the ICB in terms of dental service provision.
Thank you very much, Jane. Okay, I would now call on Munaf to introduce himself and also give us a brief overview on the key issues being raised by Leeds Dental Committee. Over to you, Munaf.
Okay, hi. Thank you, Chair. I'm Munaf Qayyum. I'm the chair of the Leeds LDC and also an NHS practitioner with my own practice in North Leeds. Now, as general practitioners, we're facing quite a few problems at the moment regarding our existing staff. We've got still a lot of staff being off sick and patients off sick, so we're having difficulty fully staffing all clinics. Also, practices are having extreme difficulty recruiting nurses and NHS practitioners. Some of this is because in Leeds, I think generally there's a lot of other jobs that people can go for that don't have as much stress or workload as working in an NHS practice, and without the responsibilities, without having to go get a qualification and to be GDC registered. So a lot of the workforce have, during COVID, left and got easier jobs. And it's harder to recruit new staff to come into the profession. We at the moment are advertising. We've had the advert out for 4 weeks and we've had 3 responses, out of which no one was a suitable candidate for a dental nurse. And until we've got enough dental nurses, we can't expand the dentist side. So we're having difficulty recruiting staff at the moment. And I'm not sure if the colleges could do more to encourage the young school leavers to go into dental nursing. It would help. There's talk about the changes in the contract that are coming in that were announced in July. Now, the contract came out in 2006, and in 2008, a review said it wasn't fit for purpose. So it's taken 14 years for us to get these minor changes and minor improvements of the marginal gains for the dentists. Some of these changes were announced in July, but have still not come into place. And I think they may be coming into practice before the end of the month, so that dentists get remunerated better for some of the procedures they do. You could see a patient who takes 10 minutes surgery time and you do a simple extraction and you get 3 units, and you could spend the same amount of time on, you could spend 6 hours of surgery time on a different patient and get the same amount of credit for doing that work. So this was off-putting for practice to take on new patients, because you could get a new patient that would need a lot of work, so it could cause a lot of demand on the dentist on the appointment book without actually seeing many UDAs delivered for that treatment. So waiting lists are growing in practice. I know my practice is open on the NHS website, but I've got 300 to 500 patients waiting on the list, and realistically we can only see about 5 to 10 new patients a week. So we're looking at over 6 months to 9 months if I was seeing them every week. But then some weeks you see new patients that need a lot of work doing, so they'll take more time, so it takes longer to start accepting more patients off your list. Practices, some of the costs that we're incurring. If a patient brings a denture in, an NHS patient, and their denture breaks, we repair it free of charge for the patient. At the moment, it's costing me £10 more to get the denture repaired than I actually get paid for doing it. So each time a patient brings a denture to the practice to be repaired, I'm out of pocket by £10. Also, at the moment, referral for secondary services for children, we're finding, as the community services under a lot of pressure, we're finding it hard to get patients referred into either the community or the dental hospital. And the same with orthodontics. We've had a few patients on the waiting list. There were originally, the waiting lists were managed in practice by each practice themselves. and written referrals were sent to them. Now it's managed by a central service. So I could have referred a patient 4 years ago on the paper system, or 3 years before the electronic system came through. And these patients should have been passed over to the RMS, the new management system for the referrals. Patients, they're trying to validate this list, and some patients are getting letters asking if they want to stay on the waiting list, and they have to reply by a certain date. And quite often the date that they need to reply by is after they've received, before they've even received the letter, so they've not got time to do that. So people are responding, but they've not had any response. So we're getting quite a lot of concerned parents contacting practices to ask whether their children are on the waiting list, and there's no way for us as practitioners to find this out. So at the moment we are facing quite a few challenges in practices, but most practices we're all contracted to do our 100% of our contracted work. But this is where I think the commissioners have their hands tied. Since 2006, the new contract, practices cannot expand naturally how we used to in the past. So it's like at my practice, I've got a room that's empty that I could put in a new surgery and get another dentist and expand services, but I am physically not allowed to do any more services than I'm contracted to do by the NHS, which hopefully these new changes, they're saying that practices will be able to deliver an extra 10% on their services. But it's hard to plan unless you know that it's going to be recurrent funding. If you're only being told that it's for 1 year, it's hard to plan your workforce long term for annual funding and just getting it non-recurrent. So I think that's all the challenges we're facing at the moment. Thank you.
Thank you very much. Thank you very much, Mona, for your openness in terms of the challenges that you're facing, and I believe we would explore that further, so we appreciate that. Okay, I would now call on Stuart to introduce himself and give us an overview on the issues being raised with Health Watch Leeds by patients and also the public. And I believe, Stuart, you're bringing in Mandy as well. Is that correct? Excellent. Over to you.
Brilliant. Thank you. Hi, everyone. I'm Stuart Morrison from Health Watch Leeds. A lot of this has been covered, and I don't think any of this will be new, which, you know, is a bit of a shame that nothing's changed, but I understand some of the reasoning behind it. But I'll tell you what we've been hearing since the last meeting. And again, it's around general access. We're still getting calls on a daily basis from people asking for help to find an NHS dentist, and we're having to tell them that there are none, or there are a long waiting list. I think 6 months is great compared to some waiting lists that are out there. I suppose a trend recently has been the number of calls we've had from pregnant ladies and parents trying to get dentists for children. That's something that's kind of seems to be creeping in a little bit as well. The other thing we hear a lot around is, or know about, is communication. As we've heard, websites not being kept up to date. Some practices on the website saying they're accepting when they're not, or they don't mention the waiting times. People being told to go private by NHS England or dental professionals, saying that's their only real option. People telling us they get more information on options that are available from us than they did from NHS. But one person told us they contacted 111 online, was promised a response within 24 hours, and 4 days later they contacted us because they hadn't had a response. An issue around BSL, or British Sign Language interpreting. Deaf people have told us that there's no provision for BSL interpreters for their dental appointments, often relying on friends or families to interpret. Some local dentists have told us they don't know where and how to book BSL interpreters, and whether NHS England has a contract with any local provider for this service. So it'd be good if we could clarify the position on interpreting around this at some point. Accessible information standard. Now, this should be, you know, enforced with all NHS organisations. So there's a lot of people with sensory impairments and learning disabilities. They might need things like clear explanations of the treatment. And when this doesn't happen, they can become scared or don't understand what's going on. There are lots of work we've done at Health Watch that we would happily advise on. Things like recording people's communication needs, offering longer appointments, ask how people want to be contacted, offer different ways to make appointments, And this is one that's quite common around deaf people having to phone up to make an appointment. It's not, obviously doesn't work. And I think inequalities is something that is really shining through with this. Some people feeling like there is no option but to go private, which isn't an option for a large number of people. We had a recent call from someone who has an abscess in a broken tooth and was quoted over £4,000. Now, that's not something that a lot of people have, obviously. We've also had examples of dentists saying they'll treat a child on the NHS if the parent goes private. I'm not sure if that's strictly legal. Also, it appears to be affecting people with the greatest needs. So I suppose people with less stable lives, people with mental health issues, or maybe refugee and asylum seekers not knowing the system. So they can't attend appointments for a variety of reasons. So then are removed from the list and then they're in the cycle again. Orthodontics, I think, has been talked about, but for me, around that, communication was a big issue there. People not knowing what was going on and having no one to contact to find out. Letters going out really late. It appears to me to have been a bit of a shambles, if I'm honest. I'm not sure if there was any public consultation beforehand, not that I know of anyway. I think it just was handled quite badly. And then there's urgent dental care. So we hear that people do get to see dentists when they're in urgent need, but then they might just have their teeth removed or given a series of antibiotic prescriptions and then told to go and get a dentist for any follow-up care, and then they can't get that follow-up care. And I think there's confusion about what's actually in the contract as well. I think NHS England say that all dentists should take on urgent patients, and in practice this doesn't actually happen all the time. But we've also heard from local dentists that it's not in their contract and they do it through goodwill. So I'm not sure what is in the contract. One thing I will say though is that we very, very rarely, if I can't remember the last time we get any negative feedback from people once they've actually received dental care. So that's a positive. So once you're in there, it's great, I think. But for me, we're seeing more and more examples of the negative impacts the lack of NHS dental care is having on people, with mental health being increasingly affected. Sorry, I've got a couple of examples I just want to read out before I hand over to Mandy, who's got some of her own experiences, if that's okay. Person called us. I'm 23 from Leeds. I'm currently on disability benefit due to an eating disorder and mental health. I have tried for some time to get an NHS dentist due to losing my spot 4 years ago from missing an appointment. I was mentally unwell. My teeth are absolutely shocking. They've snapped all at the front, causing pain and major self-esteem problems. I already suffer with body dysmorphia and my teeth are playing a huge part. I try to keep my dental hygiene the best I can, but I throw up acid a lot. This causes rotting. I'm at a place now where I've tried to get dentists. I've rang and emailed almost every dentist in and around my area and had no luck. It's making my mental health deteriorate, and I'm feeling very vulnerable because of bullying. I can't seem to get help. Actually, I'll just leave it there and let Mandy have an opportunity. I just wonder if, I know there are massive kind of issues and we all know them, but there were some people like this person here who were in kind of real need of that treatment. It would be really good if, I don't know, somehow those in most needs could be seen, but I don't know how we work that out. Okay, so I'll just hand you over to Mandy. That's right, Mandy, you're going to share your own experiences.
Hello, my name's Mandy Sharp. I've lived in Leeds for the past 10 years. I had a dentist, but I got an emergency appointment because I had a massive tumour on the bottom of my spine, so I had to postpone one of my appointments. While I was in hospital in the ICU, I got a letter telling me that I'd been removed from the dentist practice because I'd missed an appointment. Since then, I've had 2 appointments with an emergency dentist who's no longer there in Yeadon, and he was a bit of slapdash. He was gluing teeth together and it made my teeth worse. I found out that I could actually get my GP to ring, or make contact with Richard's Dental Institute. So he sent a letter. I didn't get anything back. And then I got a letter saying, don't contact us for another 4 or 5 weeks. So I left it for 4 or 5 weeks. Then I spoke to somebody up at my local hospital at Wharfdale. And his exact words were, well, we don't know where to put you. I said, what do you mean you don't know where to put me? He says, well, you've got problems, you've got TMJ, you've got this, you've got that. So we don't exactly know where to place you. He said, I tell you what, go see your GP again and ask him to write another letter. So I went back, my GP, he was a bit, what? He said urgent on it because I'd gone for an abscess. And he didn't even know he could treat me for an abscess because at one point you couldn't even go to your doctor for an abscess in your mouth. Go find a dentist. So I get another letter, ring after the 10th, which were 10 days later, 10th of August. So I rang him again. He was incredibly rude. He said, I said, how long am I going to wait? He said, you'll be triaged. I said, how can you triage me when it's my mouth? You can't see my mouth. You don't know what's going on. I've lost 9 of my teeth at Christmas. I'm losing other teeth. They're just snapping off. And it's all because I had my wisdom teeth removed when I was 26 and it had grown straight across the top 4 of my teeth. So it had bent all my roots. So, and the bone never grew back, which often happens. So I phoned him, go back to your GP and get another letter. So I goes back to my GP, he says, what's going on? So then he gets an email from the Dental Institute referring to me to SAMS. The worst nightmare of my life. I wanted to throw myself out of my building. Your staff are so incredibly rude. The first words were asked were, when I actually spoke to yours, was, are you willing to sit in a chair and have a local anaesthetic at this point? I'm in so much pain. I'm so depressed. Yes, I'll sit in a chair. Sorry, you need to go find a dentist. Pardon? I'm not supposed to sit down. I've got coccydynia from having that operation. I've got permanent coccydynia. I can't sit down for very long. That's why I'm leant forward. So then, after I'd spoken to her, she said, phone the Dental Institute. So I suppose I phoned the Dental Institute. And I spoke to them, nothing can help me. In the end, Stuart and Gemma helped me, and they must have got in touch with pals for me. And I got a phone call from the Dental Institute and from yourselves, basically brushing me off. I might be able to get they'll give me a phone number. At the point I had ulcers, so I couldn't have been treated anyway. So it was a waste of time me going to see you. You may or may not be seen. We can't guarantee anything. Can we write you off now from this pals? I have friends. My best friend, Michelle, her son, his girlfriend's brother went to Turkey in October, only 3 weeks ago. He came back in a coffin. One night there, he was there with his wife and his children. He thought he'd have a bit of a holiday, take the family. But he thought, if I invest this money, going to Turkey, getting my teeth done, it's cheaper than having it done here. But he never came up. He's still not buried yet, by the way. His mum's on injections because she can't bear it. She's lost a son. Everyone's distraught. My other friend, she's Linda. Her mum's diabetic. She was a nursery nurse for like 45 years. She kept up with a dentist, but she had a stroke. She's got severe diabetes. She's got leg ulcers. She takes warfarin. She's had 2 strokes. The dentist was upstairs. She couldn't get upstairs. No problem. Linda called at the house and she'd actually pulled her own teeth out with a pair of pliers. Nobody can access a dentist in West Yorkshire unless you're sent 30, 40 miles away, which, to be fair, if you've got to catch a taxi or you go into an area you don't know, you get a taxi, which costs you like £30, £40. Nobody can afford that each way. And all you get from people is, I'll put you on a waiting list. How long's your waiting list? In Otley, it's 10 years. 10 years. I look at myself. 2 years ago, I had a full set of teeth. I've got nothing now at the top. I've got this look. I look like a drug addict. People look down on me. I'm laughed at. I usually wear a mask, but I'm not going to today because you're all dentists and you're all saying you're doing this and you try to do that and you try to do this. But nobody's actually thinking about the people that are phoning the girl 2 doors away from me. She has to go on 3 buses and take a day off work to go to her dentist because she daren't give it up. Because if you give it up, you won't get another one. I phoned in January to get a dentist because I told you I lost 9 at Christmas. I don't know why. It's the medication I take. It's actually exploded my teeth. They've actually exploded and the teeth are actually expanding. So they're going to the roof of my mouth, which is really, really hard. It's hard to eat. It's hard to swallow. I catch my tongue all the time. I bite my lip. And then in January, the only place I could find was in Keighley. I live in Otley. And it was January 2023. I wish I would have taken that offer of having an appointment in January 2023. If I'd have known this. I know you're all trying hard. I know you are. There might be a shortage. But several dentists offered me to see me the following day for £80. £80. Your dentist is the first port of call. Oral cancer. If you don't have your teeth fixed, you can get problems with your heart. You can get heart disease. It can cause strokes because the jaw here, if that swells up, affects your brain. That can cause a heart stroke. People are finding out it's having an effect on the autoimmune system. So people are getting, having the teeth done properly. They're getting arthritis. I've done a lot of study on it, trust me, because I went like a dog with a bone. I want to find out what's what. All I want is not just for me. I did a survey back in April on the Leeds website. I first did it in Otley and I got 2,000 families. Some of the children are 15 and never seen a dentist because they can't find one. So it's been going on a lot longer than people think. Begging to see a dentist. What happened to the school dentist? When I went to school, we had a dentist that came in twice a year, inspected the teeth, taught the kids how to use the tooth and toothpaste, helped them. Oral hygiene's the way to stop things like this happening. So we don't end up with problems. But dismissing people as well when you get to a point of contact, or being offered, oh, if you've got £80 come in tomorrow, we'll see you. Well, once you do that and you step over that line, you can never go back on NHS. Once you've gone private, you can't go back to NHS. That's it. You're done. I have got so many people that have reached out to me. Then I did a Leeds survey. They actually took it down after 2 hours because there was 7,000 responses of people, old people, young people, desperate to see a dentist. Not everybody's reaches out to Stuart because they don't know about Health Watch UK. They don't know about Health Watch England. They're trying 111 and they're sat on the phone for like 3 hours. They've got to give up. They're eating away at the credit. How many people can do that? I know there's lots and lots of packages on your phone, but to sit there for 2 and 3 hours, not being able to move, just in case they answer you. And like you said, I was lucky, I did get a response back in 48 hours, not 24, 48. I did get a response, but where they offered me to go was absolutely insane. It would have cost me, I think I worked it out to be £68 in a taxi, there and back, which I can't do. So I'll be quiet now. And I'm sorry, I didn't mean to rant, and I'm sorry, but you really need to teach your staff. And Richard, you too. train your staff to be more kind, because I really did nearly throw myself out of the window. If it hadn't been a locked window, I would have been out there. The way they treat you is disgusting. Oh, we can't do anything about it. Go find a dentist. Go find a dentist. How the heck? That's why I'm phoning you, community dentist, the dental school. Your dental school's not open to the general public. Everyone else's is. You've got to be referred. Be referred by a dentist. Well, if you can't get a dentist, how do you get referred? To be fair, I think the full way forward, if you want my opinion, is get yourself some vans like you do for the homeless. £5 parking like Hofdale Hospital, Chapel Allerton Hospital, Wakefield one day. Move them about every day. Get £5, 2 dentists on each van, and move around. Because I'm telling you, mornings doing like one extraction or thing, and then the afternoon for longer appointments. That's the way forward. I mean, it's all right waiting for this money to come through and waiting for that money. Something needs to be done now, because you're going to have a lot of deaths, septicemia, strokes. They're finding out more and more illnesses about it. I'm sorry, I'll shut up now. I'm sorry.
Thank you very much, Mandy, for that very heartbreaking story that you've shared with ourselves. And I just want to assure you that you are the voice of so many in this city. And what you've come here to tell us today is the reason why we're sat around this table. And we have not just invited NHS England and the Dental Institute to just come and talk to us. We also wanted to hear from the public, from patients, and from yourself. And I can assure you that you have spoken for so many people today. It's painful to hear. We do, yeah. Which is why, you know, we really just needed to listen and hear you. And we're all sat around this table to find a way forward, because we do not want anyone, not just in this city, anywhere, to go through what you have gone through. And I am so pleased the Dental Institute, Sam, the team, you all have heard directly from Mandy, and Mandy today is the voice of those 7,000 that have called Health Watch, and plus a lot of people who do not even have access to a mobile phone to even make a phone call to say, this is what I'm going through. Never mind even trying to get access to a dentist. And that's why this particular scrutiny board has been very, very patient, just waiting for all of us to be sat around this table today and make sure that something is done about the oral health of this city, and not this city and the region as well. I believe, Sam, you would like to come in briefly, and then I'll call on the exec members if they'll want to say anything before board members come on board. Thank you. Over to you, Sam.
Thank you, Mandy. I just want to apologise for the way that you have been spoken to in our service and not been able to get the access that you needed. It's certainly not what I would expect. I don't want to take up too much time here, but I'm very happy to take your circumstances away and come back to you and see what happened there, with an apology from the service as well as myself.
Thank you.
Thank you very much. Exec members, any one of you would like to come in here before? Yes, Councillor Arif.
Thank you for that, Chair. Mandy, that was really heartbreaking. Thank you for sharing. I guess with my hat on as a councillor representing Gipton Hare Hills a couple of weeks ago, I was out with a local youth service, and I just tagged along. They were doing house visits in the area of Hare Hills. We walked into this particular house. There were quite a few young kids. Mum and dad, their first language wasn't English. We picked up that one of the young kids was not well. He was complaining of pain in his head and headaches and pain in his jaw, and he'd stopped going to school. This youth service, this organisation helped mum and dad sort of navigate what, you know, is difficult for anybody, but particularly with parents that don't have English as their first language, in terms of finding a dentist. And they said this was back in October that he could have an appointment, I think in February. The problem we've got is, you know, he's not going to school because he's in so much pain. So I think the impact of what this means for some of those kids in not being able to have access to dental services is actually they could miss on their education, and also for families that don't know or don't have the language, and that's a barrier for them as well. So it was just something that stuck with me, and we're trying to do what we can to help this young family. That's all, Chair. Thank you.
Thank you very much, Councillor Arif. Did you introduce yourself? I don't think so.
Forgive me, Chair. I'm Councillor Salma Arif. I'm the Exec Member for Public Health and Active Lifestyles. And as I said earlier, I represent Gipton Hare Hills.
Thank you. Councillor Venner.
Thank you. I'm Councillor Fiona Venner. I'm the Executive Board Member for Children and Adult Social Care and Health Partnerships. So dentistry is under Councillor Arif's portfolio rather than mine in terms of being public health. But as a ward councillor, I would say it's probably the health complaint we receive the most is about dentistry, much more than I can't get to see my GP. I think also I've had quite a flurry of complaints as well because people assume it's my portfolio, and I would say it's not an exaggeration to say it's the issue around health that we get the most complaints about as councillors. I think what surprised me is the issue around including people who've got a right to dentistry. So I've had casework from foster families who can't get appointments for children who are looked after, and we know that's a really important, including children who are unaccompanied asylum-seeking children who are being looked after in Leeds. And we know that oral health is a real issue for children looked after, that obviously children come into our care primarily because of abuse and neglect, and that often means their health needs haven't been attended to and they have really poor oral health. And it's really shocking hearing I didn't know all the stuff you said about the health impacts it can cause, and it's really shocking to think that it's yet another health inequality that children are dealing with who've had a really difficult start in life. So my particular interest in this discussion really is around children, particularly looked after children. But I just wanted to conclude really by saying thank you for sharing your experience. I think it's a really generous thing to do, to share a really negative, difficult experience in the hope of making things better for other people as well as for yourself. So thank you very much. Thank you, Chair.
Thank you very much, Councillor Venner. And I know with your portfolio with looked after children, you did write to us specifically on orthodontics. So we do have that on the agenda today to explore. So thank you very much. One of the good things about this board is the experience of lots of the board members and their expertise, and been a great board we've been working with for the last 2 years. So I will now first of all call on Dr. Bill, who obviously he's declared to let you know that he's a member of the British Dental Institute, but a retired dentist himself. So I would like you to set the scene for us, and then board members, we would be open for you all to make comments and also ask questions. So over to you, Dr. Bill. Thank you.
Thank you very much, Chair. Can I reiterate thanks to Mandy for coming and sharing her story with us? It's very powerful story. And can I thank you, Chair, for allowing a patient voice to be heard, because so often we hear from, the commissioners and the providers, and we don't actually hear from the person who actually it's all about. And that is very valuable for us to hear it. I have to say, looking around the table, and thanks to all those who've come and shared with us today, the one organisation that I would like to have been in front of us to ask some questions and make some comments is the government. Because at the end of the day, the problem is one of finance. And whether it's a Conservative government, whether it's a Labour government, whether it's a coalition, it's not possible with the money that's available to provide a comprehensive dental service for everyone. And we've either got to do one of two things, or the government's got to do one of two things. They've either got to put more money in, and of course we all recognise the financial situation as it is at the moment. That may well not be possible. Or they've got to come clean, and they've got to say, if we want to have a dental service for everyone, it has to be a core dental service, a restricted dental service, and not a comprehensive service, with the money available in order that everyone can get access to some dentistry and get them out of pain, get them out of trouble. Then we might not, sadly, and I would really regret it, of course, might not be able to offer comprehensive care for the current level of funding in the system. But we haven't got the government in front of us, so I can't say that to them. But can I thank all those who have made their comments today? And I'd like to just restrict a couple of questions to NHS England. And thanks, Emma, for a very comprehensive report, and particularly some of the things you've said in it. Do you know, one of the things that makes me very cross is politicians, and again, it's from all parties, saying the NHS free at the point of need. Dentistry, well, I was going to say never has been free at the point of need. It was in 1948, but within a couple of years, charges were introduced. And you have pointed out quite rightly, Emma, that it is a subsidised dental service. And in fact, the amount of subsidy the government have put in over the past decade or so has actually reduced as a total cost of the service. So I think we need to bear that in mind. But I just want to pursue this subject of hearing the voice of patients. And I went back to the NHS Constitution for England, and there's a phrase, a clause in that constitution, working together for patients. Patients come first in everything we do. We fully involve patients, staff, families, carers, communities, and professionals inside and outside the NHS. We put the needs of patients and the communities before organisational boundaries. We speak up when things go wrong. So I want to just pick up on two of the things that are in the Health Watch England report and say, where was the voice of patients? And the first one is the rapid oral health needs assessment. I have to say, that was very good at looking at what are called the normative needs. That is, the number of decayed, missing and filled in this population and this age group and so on. A very good piece of work. But where was the voice of the patients? I did, and Emma will remember, I suspect, at the Dental Commissioning Executive, of which I was a member before that executive was abandoned. I was representing the local health watch across Yorkshire and the Humber. And I was not allowed, I did ask, I was not allowed to see a draft which I could share with the health watch across the county. Because I know Emma says that she had access to the Health Watch reports, but there's a lot of information that Health Watch have that doesn't get into the reports, such things as Mandy has been talking to us today. That's not included in detail in the reports, but Health Watch know about that. And yet we were denied the possibility of sharing that draft in an early stage to the Health Watch across this region, so that we could hear them, if not a whole load of individual patients, we could hear them as representative of the patients feeding back what they knew about the needs, not just in terms of how many decayed, missing and filled teeth, but what the impact of that was on the individuals who were the potential patients and often weren't able to become patients. So what steps did NHS England take to listen to the voice of patients? And the second thing is the review of the community dental services, which is supposed to be published, I think, in the next week or 10 days anyhow. And again, at the Dental Commissioning Executive, I did make the suggestion that if you were going to do a review of community dental services, which is, I remind you, a special needs dental service for patients who aren't suitable for treatment in general dental practice for a whole range of reasons, but includes people with mental disabilities, with learning disabilities, with autism, for instance. Wouldn't it be a good idea to actually talk to the third sector communities which represent and support people from those communities, and has told, no, we're not doing that. I have to say, actually, my concerns were not only with talking to the third sector communities. I do personally have concerns that the community dental service doesn't see patients who fall out of the system entirely. They do have learning disabilities, they are autistic, but they don't even get into the system for referral to the CDS. And Sam said it's a small community dental service. I couldn't agree more, Sam. Absolutely right. And my very cursory look at how Leeds compares with other core cities, with Manchester and Liverpool and Birmingham, is that we have, for our population size, a very small community dental service. I think those with special needs in this city are entitled to a larger chunk of community dental service than we get. And that should be in the review of community dental services. My question to Emma is it? Thank you, Chair.
Thank you, Dr. Bill. Over to you, Emma.
I'll pick up those points in the way they were questioned. So I'm sorry that you felt that you weren't allowed to see the oral health needs assessment, Dr. Beale. I think it was the first of the type that we've conducted in Yorkshire and the Humber and West Yorkshire. I think we have lots of learning to do from it. It is not a definitive document. We would really like it to develop and expand. We have, I think what we probably said is it's a point. May 22 was when we presented it as the document as it was then. We've gone on then to develop those place profiles that I referenced. And one of the things that I've asked the team to do is to think about how we engage with our local dental network and colleagues as we move through the next sort of weeks and months. So it's a point in time, and I think it's fair to say that we've learnt a lot from it. We've certainly had feedback about where we've collected our responses and our thoughts, and I would really like us to do that. It's one of those documents, I think, that would be difficult to end, to have a finite position. People have different views about what an oral health needs assessment will do and how it will impact on us trying to find the solutions that we just heard about today. So I'm really, really keen that that is seen as that, and I would very, very much welcome feedback from colleagues. We have talked in the dental network about how we engage not just Health Watch as a voice, but also our other colleagues and get some of that patient feedback. And I have brought somebody in the team to do that. So to work alongside our consultants who are developing the needs assessment and then thinking about how we do bring in some of those broader themes and feedback. So I hope that there is some confidence from colleagues that we will actually see that as a developing piece of work. I think one of the things for us is the fact it was the first time that we'd done it, and we just wanted to make sure that we had something for reference. But I completely take the point that we need to be broader in our thinking. So that's the first point. The second is the CDS review is ongoing. It has already produced its first sort of recommendation, which is, given the breadth of work that we need to do to undertake in terms of the CDS review in the way you described, Dr. Beale, one of the things we need to do is to make sure that we've got the services in place to be able to engage with and the patients that use that service, how we might manage that. And unfortunately, our contracts were due to end, which would have made that very difficult. We would have been finding ourselves in a situation where contracts were ending and we were trying to review at the same time, which just seemed completely disingenuous. So we are looking to extend the contracts with our providers so we can continue with that review to make sure that we do engage with our provider colleagues and the users of the service. And that will be happening over the next week or so in terms of communication. And again, because the CDS review is taking part as part of my team, I would really hope that we can make sure that we've got all of those voices. And I would certainly take feedback and confidence from colleagues about how we would best do that. And I can give you details of who would be leading on that and be able to take those thoughts forward.
Thank you very much, Emma. Any supplementary questions?
No, just to ask Emma if the review as it is at the moment does include a comparison of Leeds with other core cities.
the service that we commission is across Yorkshire and the Humber, so it does engage across different providers and different localities within our patch, yes. Good point. I'll take that. I'll have a word with our clinical lead and find out if that's the case. But yeah, that would be the next stage for the review. Okay, thank you.
Thank you very much, Emma. Thank you, Dr. Bill. Any more questions from board members? Yes, Councillor Anderson.
Thank you, Chair, and thank you to everybody who's spoken this afternoon. But what I haven't heard this afternoon is which of you are concentrating on prevention of tooth decay. What are we doing about children not getting tooth decay in the first instance? I mean, apart from the parents being responsible, who is responsible amongst you all for trying to do the best for children? And I mean, these in this rapid oral health needs assessment, it's absolutely shocking what's happening with children's teeth. That is entirely preventable.
I'll just add here that takes us perfectly into talking about orthodontics. So is it say more? Okay, right. So what I would say, Councillor Anderson, because we've got another session for orthodontics, I'll take her own question and then we finish and then move straight into prevention as well, because that's really important. Councillor Burke.
Thank you, Chair. Kind of an open question, really, but trying not to look at anybody particularly for an answer. All your presentations were really interesting, and I've got a vested interest because I've taken part in international trials around bruxism. So you're absolutely right about the additional health impacts. But some of it sounded to me, and I apologise if this is quite rude, as kind of excuses and mitigation, when people's dental care is at the heart of everything that should be important. And I don't apologise for using the term excuses and mitigation, because I know everybody's under stress. For instance, people are thrown off dental surgery lists if they miss an appointment. I know everybody's busy. So my question is there anything we can do to perhaps review why they've missed that? And I know there's a resource implication about ringing people up or writing them a letter, giving people a second chance. But, you know, if people, particularly today, there's lots of mental health issues, people are suffering more stress. It just seems so harsh, final and cruel to say you've missed an appointment, you are off, and then perhaps facing years of not seeing anyone. That my question, is there anything we can do to mitigate that?
At my practice, all patients are sent a text message 2 days before the appointment so that they're not reminded about the appointment. And if someone, even at our practice, on the appointment cards, everyone is asked to give us 24 hours notice so that we can reappoint that appointment to someone else. Now, at my practice, if you were ill overnight and left a message on the machine or rung before 9:30, even if it's for the day, we let you off. We class that as a cancellation, even though it's short notice. If someone has missed an appointment, at my practice policy is we do give them a chance. But when someone has repeatedly missed 2 or 3 appointments that are 40 minutes long, I've still given some people exceptions where the children have been looked after children or children with some specific issues. But generally, when a patient will sometimes ring up half an hour after the appointment, say, oh, I'm sorry, I can't come, I had to go to work, or I'm not feeling well. If they've done that more than twice, we can't afford to keep them on the books, because then it's taking time that another patient could use. And also then, as a practice, that half hour, 40 minutes that the surgery is sat empty, we're still having to pay the staffs, and we've got to hit our target, so we can't do that. Now, as a practice, we could take more patients and expand the service, but because of the way the contract is, we physically are not allowed to do extra. So at my practice, I've got 2 NHS dentists, including myself, and 1 private dentist. So if you were a patient and you missed 2 or 3 appointments with me and you wanted to come back to the practice, you would be offered an appointment. But at that stage, you've lost your NHS appointment because you've wasted nearly 2 hours of surgery time.
I come back. And thank you for that. And I know all practices perhaps operate differently. So what I'm getting at, perhaps we need a unifying approach to it so that no matter which practice you are, and some practices will be more lenient than others, that people are treated in a very similar manner wherever we go. And I do appreciate your point about wasting time and how expensive that is, but perhaps there's something for us in that. And for us, I mean, my exec board members and public health, my colleagues, around some kind of education about, for people, maybe a campaign about how important it is. But there are some people who it's unavoidable because of a whole variety of reasons. So perhaps we need a unifying policy.
Absolutely agree, Councillor Burke. Emma.
I think that's a really good point. And actually the colleague that I was talking about that I've brought in to help me with some of our communication and engagement, that was exactly the conversation we were having last week. We've got a piece of work that we've just started that is going to help us understand what we mean by waiting lists for practices. Many practices, that they all manage them differently. Some will say it's 3 to 4 years, some will say it's 10 years, but you'll be aware that patients can sit on a number of different lists, so they've never been validated. So we've just started last week a piece of work with practices to help them understand the waiting list that they have and start to think a little bit how they could prioritise those patients. As part of that, what we're saying is, what's the so what? So if we know that, and practices know how many patients they have waiting and the breadth of need that they have, what can we do to help those practices communicate with patients and help them understand some of the things like implications if you don't attend, etc. So we are looking at trying to build some protocols to help practices, helping them with some communication tools, but also going back to Dr. Beale's point about patient engagement, thinking from patients what would be helpful for them to be aware of when they're booking their appointment or when they're trying to book. So there's a practical piece of work happening that started last week that will hopefully bring us to a better place in terms of patient communication.
Can I come back on time? Thank you. And perhaps that could be, sorry if I'm speaking for other people, but perhaps that could be joined up so that we can actually speak to people on the ground and our constituents, because that's where the message. And I've just got one last question. It's very quick. We spoke earlier, or you spoke earlier, the collective view, about increasing capacity. And in the document here, there's a passage about increasing capacity by 10%. That looks fabulous when it's written down, doesn't it? But I continually hear about how there's a shortage. So we can throw money at it and we can increase the capacity. But in reality, if we don't have the dentists and we don't have that, I'm not sure what that means. I'm not sure what that means on the ground if we don't have enough staff.
That's another really good point. When we say we've increased capacity, we have offered funding for this year, so this financial year, to practices to be able to put on some more appointments, both for patients who have an urgent need, but also those who would like to be seen as a regular patient. The feedback that we're getting from practices is if we can give them more sustained funding or over a longer period of time, then they can think more creatively, they can recruit. I think my dental colleagues will say it's far easier to be able to recruit if you know you've got funding for say 6 months than it is to say here it is for a month. And we are seeing some and also an opportunity to retain staff. It's not just about recruiting staff, it's also about retaining. So if we're saying, actually, here's some additional funding, you could put on some additional appointments, where the feedback we're getting, not for everybody, but certainly for, actually they can retain staff because they can offer them a little more work or a little bit more opportunity to do some additional appointments. It's only one of the issues that we've got, but that's one of the things that we're looking at.
Thank you very much. I've got a few questions, but I would like us to move on to orthodontics. And then if we do have time, I'll bring my questions in. I believe, Emma, it will be back to yourself. And really, we would like to know, just give us a brief explanation on the re-procurement process and the current position for orthodontics, please.
And Jane will be able to help with this as well as our orthodontic lead. So yes, we have undertaken a procurement across Yorkshire and the Humber for orthodontic services. So that was to ensure that we had one pathway for patients, and the criteria for being referred in is consistent and same across all services. We have managed to, with great success, I think, identify providers to be able to deliver those services. Unfortunately, in Leeds, there were specific challenges with regards to what's called wind down contracts. And that is contracts for those dentists that already have patients in the service and have them under within treatment pathways, and then them been taking the contract to continue with that. So unfortunately, and I know from the number of letters that I received from yourselves, from your colleagues, from patients, and engagement that we had with Stuart and colleagues, that that was a real challenge for patients where their provider suddenly was saying they weren't able to provide the service. There's no obligation for a provider to take a wind down contract. So for us, we then had to find capacity elsewhere. Also, one of our providers that we procured was a little later in starting than we would have liked. So it has presented us with a number of challenges. And I have to say as well, an opportunity for us to review how we would manage procurements in the future. This was one of the larger procurements that we've done with a number of different lots. And whilst there were major successes in many of those areas, for Leeds specifically, there was that challenge. We have now sorted many of those problems out. We have the capacity, and patients have been communicated with. We have some outstanding issues, and I think colleagues have referenced it, that some of the letters have been a little delayed getting out to patients to advise them of their new arrangements. We suspect that might have something to do with the post strikes, but that's anecdotal in the short term. But we're picking up those issues through our contact centre and complaints process. So I have had several conversations with colleagues, MP colleagues as well, who have been in touch with us. So we do think that most of our patients now are aware of the situation and have been able to feed back where those arrangements have been made and are not suitable for them. So that's our next stage, is to pick up, because obviously some patients have been allocated to a new provider that's not always as local as they would like. So we've now built that additional capacity in so we can respond to that.
Okay, thank you very much. Did you say Jane was going to come in as well?
Yeah, just to say that we do recognise that Leeds have been particularly difficult with a big provider not accepting a wind down contract. The team have been working every single day on making sure that the patients that would have been part of that wind down contract were allocated new providers, and even down to individual patients. We have been working hard to make sure that they all had an orthodontic provider to continue their treatment. And they have all now been allocated to other providers. They have all got a place to go. And my understanding is that all the patients are being communicated with and do understand where they are to go. So it has been a huge piece of work. But it is pretty successful now. The other thing I would like to say is that the referral management system, the electronic referrals, have been designed to prevent the big waiting lists that historically built up. We are still in a transitional place at the moment whereby we have had patients who were referred on the old paper system transferred into the new referral management system. They have all retained their individual place on the waiting list at the time and point of referral. So the patients have not lost out by being transferred onto the electronic system. But going forward, all practitioners now refer on the new system with an electronic form that gives much more clinical detail and makes sure that the right patient who is suitable and eligible for NHS treatment is sent to the correct provider. So we will not have the huge waiting lists going forward that we have had in the past, recognising that we have a transitional period to go through before we've worked through the old ones that were referred on paper. But we are still working hard on this as I speak.
Thank you very much, Jane. Could I ask Munaf or anyone from Health Watch if there's anything you would like to add from your own perspective on orthodontics, please.
No, I think the orthodontic referral system is working really well, the new RMS electronic referrals, because in the past we were getting a lot of patients where we knew they probably wouldn't be suitable, or the parents knew there was a 3 or 4 year waiting list. So before the child was at the appropriate age, dentists were getting almost bullied into referring these children onto the orthodontist. So I think historically they have had big lists, and the RMS is reducing this, because then it shows us a way of telling the parent, no, actually they're not suitable for NHS treatment. So it stops them going onto a waiting list inappropriately. Regarding patients being told where they are, I think the majority of patients at North Leeds have been told who the new provider is, but I am still getting the odd patient contacting me, or practitioners from other practices contacting me as the LDC chair to let me know where patients haven't had a new provider allocated, or they're having issues, in which case I normally get straight onto the commissioning manager, and she's been really good at allocating this patient or finding out who's going to be the provider and finding the information for them. So things are settling down, but I think generally in West Yorkshire there's probably not as much orthodontics commissioned as could be, but that's the same with all the dental services. We're not commissioning enough services to cover the population. Thank you.
Thank you. Stuart?
Yeah, thank you. And I agree. I know yesterday I got an email from someone I was trying to help saying, yeah, they've received the letter. But has it been, did this start in April? The whole process? Because it's, you know, it's taken a very long time, and people shouldn't need to be contacting Healthwatch or a local MP. They should have someone to contact to know where to go with, you know, questions about what's happening with their child. I kind of would like some reassurance that there's learning from this in around the whole communication with people, because a lot of the time, if people, even if they're told it's going to take a while, you know, but if you have got any issues, call this number, that'll be better than just waiting 6, 7, 8, however many months.
Really fair point, Stuart. And I think, as you know, when we've had our discussions, yes, we do need to learn from this. I think that the common theme hasn't just been the patient experience, has it? But it's been the patient communication and our communication with patients, and not just patients, but parents and other aspects. So I totally take that point entirely. Some of our services started in April, some in June. So it has been a phased approach in terms of bringing those services on board. But I take your point entirely. It shouldn't be who you know. We should have a clearer. And I think we thought we'd put that in, but we didn't quite appreciate the volume that would come through. So we did make every attempt to do that, but it was enabled to be able to respond to the volume. So I think that's a fair point, and I would take that as a learning point for us. Thank you.
Thank you, Mandy.
I'd just like to make a point. You're all talking about people or children that have already got dentists. There are tens of thousands of children in Leeds that don't have a dentist or an orthodontist. Why don't you set it up to go back into schools, get them at the point? We used to have a dental service that went into schools twice a year. Well, what happened? That's where it's gone wrong. You can catch them then. They get used to seeing a dentist. They're not scared of dentists. But you're not taking into consideration. I know there are tens of thousands of children in Leeds, Bradford, Wakefield, Humberside, who have never, ever seen a dentist. And you're not taking them into consideration. Oh, we're just moving this and we're moving that, moving this. Yeah, but what about the people that are already on? You're not thinking about them.
Thank you, Mandy. And that sounds like some of the preventive measures that Councillor Anderson is making reference to. I think, Una, did you want to come in? Yes, please.
I was just going to say, regarding children, in Leeds, we have there's 23 flexible commissioning practices who do take referrals from the 0 to 3 visitors and 0 to 19. They do take referrals from the community dental service. So once a child or a person has finished their course of treatment, they'd be referred into general practice rather than staying with the community dental service, which will relieve some of the pressures on this. And a lot of with the 0 to 3, we're trying to get the children in soon as literally they're born, before they've got any teeth, so that we can give the relevant advice to the parents. And we're seeing this programme is working quite well in Leeds. And my own practice, we've taken quite a lot of referrals from the 0 to 3 and the 0 to 19 team. Originally, the programme wasn't set up to take patients who are that looked after children or from care homes, but we are starting to find that referrals are coming through to the flexible commissioning practices to take children who are looked after, or asylum-seeking children. I've had a few myself. These weren't contracted with the flexible commissioning practices, but the practices are doing this so that we can give a preventive approach and try to get these children young, so that hopefully we never have to do any treatment on them. So there are some programs doing this in Leeds at the moment, but I don't think maybe they're as widely known as they should be. I think the health visitors and the 0 to 3 and 0 to 19 team do know about it, because they are referring patients into practices.
Okay, I think the key word there is some. So it's knowing how many compared to the population that we've got in Leeds, because obviously if it's only a chosen few or a privileged few who are having access to this, then our problem still remains. So it's actually establishing and knowing how far reaching this service is available to all children in the city, and not just a particular demographic or area of our city. Sorry, I'll bring in Victoria and then I'll come back to you, Emma. Thank you.
Thank you, Chair. And just to introduce myself, I'm Victoria Eaton, Director of Public Health for Leeds. I mean, there's lots of issues there, we've got the fluoridation information in the pack as well, which I'm more than happy to come back to. I guess just from around the conversation about prevention and wider dental public health and oral health promotion, I think it's probably worth just sharing a couple of things. I mean, clearly there is a fundamental issue of people's access to dental care, which then picks up preventative elements. So, you know, obviously that's a huge issue, including children, but broader than children. And I'm really grateful, Mandy and Stuart, for all of the comments you made earlier. So I think there's something about as colleagues just described over there, how you build that into services, because that's partly what good dental care is, not just treatment, but keeping people's teeth well and healthy. So there's something about access that's at the heart of that. I think the other thing to just to share with the board, and I know Dr. Beale is more than aware of this from his own experience, is that up until the health reforms in 2013, dental public health was part of local public health teams and the responsibility of the local director of public health. And in the 2013 changes, that was separated. And so we now have a situation where we work really closely with our colleagues in dental public health who sit in NHS England and join up the fact that it's not all together in one team. And, you know, that's obviously harder to do than having it in the same team, but we make that work for our population as well as we can. The other thing that it's important, and Emma, my colleague Emma Newton, can add some examples of, is that with the people that went from local public health teams in 2013, also all of that resource went with the function. So we now have a very small programme of work that we use our general public health grant to fund, which looks at some of the things you've just described about work from health visitors, school nurses around healthy brushing and getting young children used to using the toothbrush, supporting families, etc. So there is some of that work going on. We'd love to do more, but obviously we need to look at, you know, where the resources come to support that work. But I mean, if it's helpful, Emma can talk through a little bit of that, and I think also to share also about there's work around children and young people that's joined up through the network as well. So I hope that's helpful, Chair. Thank you.
It's very helpful. Thank you very much. Emma, would you like to come in, please? Thank you.
Hi, good afternoon, everybody. My name's Emma Newton, Interim Health Improvement Principal for the Children and Families Public Health Team. So yeah, just as Victoria said, I currently chair the Oral Health Children and Young People's Group, which involves some of the partners and organisations around the table. And we meet regularly to look at the health needs of the children in Leeds, and also to look at any sort of new initiatives or ongoing initiatives that can contribute to sort of reducing the dental decay. So just a few examples of this. We currently commission the 0 to 19 service. So that's the health visiting school nursing service that also has the integrated element of an oral health lead in that team. So they're responsible for the annual oral health epidemiology survey. So every 2 years, the 5-year-old survey is done and we monitor the needs of that age group. And they're also responsible for the supervised toothbrushing scheme, and that's in targeted primary schools and early years and children's centres across the city. In addition to that, there's the Brushing for Life scheme. So that's at the very early ages. So we're talking at the sort of 6 to 8 week development check. They're already going out, providing toothbrushes, providing toothpaste, and giving those oral health messages at those really early stages, and then reinforcing them across the development reviews as they go on. They also have a training remit around that. So again, increasing capacity. So working with children's centres, schools, both primary and secondary, again, to get people to reinforce those oral health messages in schools. And they're currently working on an oral health award, which links with the Healthy Schools Award. So looking at building sort of champions across the services. Just in addition to that, we also commission the Health and Wellbeing Service, so that incorporates the healthy schools. So they do a lot of work around food policy and also around implementing the curriculum. So it's actually a statutory requirement in health education to incorporate some key oral health messages through both primary and secondary. And then finally, sort of in addition to this, there's the wider healthy eating work stream. So that includes the Henry programme, which is for 0 to 5 and the 5 to 12s. And that's around sort of not just healthy eating, but sort of behaviour change and wider sort of management. Yeah, and I think I've covered everything. Thank you.
Okay, thank you very much, Emma. That's very helpful, especially knowing those preventive measures that are currently in place. And is that in all schools across the city?
So it tends to be targeted schools, but it's a rolling programme. So they don't work with the same schools all the time. But what they're doing essentially is building that capacity within schools to be able to upskill the teachers to then be able to continue to provide those messages.
Thank you. When you say targeted schools, what does that mean?
So we tend to look at the most deprived schools in the city. So looking at the wards where there's sort of deprivation and focusing the efforts there, and then building, as I say, as a rolling programme to continue working with.
And is that from data that shows that you've got children with more bad teeth in those areas? Or
yeah. We use that
data.
We've got the data from the epidemiology survey,
right,
but also from the healthy schools who do the banding of schools and sort of identify those schools in most need.
Thank you very much. Councillor Renshaw and then Councillor Arif.
Thank you, Chair. I'd just like to ask about the correlation between the dentists and the orthodontists. And the reason I ask that is because I'll declare an interest in it's regarding my own daughter's treatment. And she's attended dental surgery since she was about 2. And it wasn't until I questioned the dentist about why her teeth weren't forming straight that she got referred on to the orthodontist. And after 5 years, she's still not completed her treatment there. Surely that could have been avoided had the issues that she's had been identified at a much younger age, which would have given opportunities for other people to have treatment. So I'm just wondering, based on my own experiences, how many other people may be having similar issues where orthodontists could have other patients taken on if the dental surgeries were doing their treatment properly and identifying issues.
Yes, Jane, thank you.
Okay, what we do is we monitor the child's development with regard to how the teeth are developing right from the earliest age. And then they're referred to the orthodontist at the appropriate age for treatment. It's not something that you can prevent by doing something earlier. The child is always referred at the appropriate time to the orthodontist.
Based on what my daughter had was a tooth growing in the roof of her mouth, and had I not have said, what's happening with the teeth because they're not growing straight, and she was x-rayed in the mouth to identify this tooth actually growing in the roof of her mouth. That could have been identified much younger. It would have been an easier issue to resolve, and it wouldn't have required an orthodontist for at least 5 years.
It's difficult to start talking about an individual case, but I can tell you that that is a common thing, something that we screen for, and something that we wouldn't normally identify until the child was around about 8 or 9 years old. Well, I don't want to comment about an individual. I can only tell you what I would do as normal clinical practice.
Okay, thank you, Jane. Councillor Arif, and then Councillor Burke and Dr. Bill.
Thank you,
And then
Chair.
we'll move on to the next.
Thanks, Chair. Just to say, following on from what Emma was saying, I think it's been about a month now. I was at the Chapeltown Children's Centre, and actually I did see visibly, I saw the most gigantic tooth brush and the teeth, and we asked, and we were told that that is part of the work that's done with children, but parents as they come along in terms of the prevention work of what's good practice. So I did visibly see that with my own eyes, and it was something that they felt it was really important to do. So just thought I'd share that. Thank you.
Okay, thank you very much. What we would love to see that is this is carried, completely around the city, but I appreciate that you have targeted areas, but it will really, really be good if we can, make sure this goes out to all areas. Councillor Burke.
Thanks, Chair. Again, I've got this idea that the more we unify what we can offer, the more further our services will stretch. So it around prevention, it just strikes me, why don't we tie in with prenatal services? Because the same people who live in those disadvantaged areas are the same people who are going to the prenatal services. So why wait until the babies are born and then we'll all panic? Why don't we start some work about the importance of dental care and a whole host of other things at those prenatal? I appreciate some people don't get to those appointments, but it would be a start.
That's exactly what we do. So we have, I sit on the oral health advisory group that Emma was talking about. We have programs to inform midwives and the nurses. We've done a lot of work around baby clinics, and this is the whole preventive message that we get out as early as we possibly can. And we have a national programme which encourages all parents to take their children to the dentist before the age of 1 as well. So it's an entire programme of prevention that's targeted right from the expectant mother onwards.
Thank you, Emma. Dr. Bill.
Thank you, Chair. Just like to thank Emma and Jane for the work that they are doing, because Councillor Anderson is quite right. We need to be preventing the disease in the first place, adopting what Leeds calls the left shift, other places call it an upstream approach. So that's very important. And thank you also to Victoria Eaton for her paper on water fluoridation. Now, I have to declare an interest here because I am the Vice Chairman of the British Fluoridation Society, and part of my PhD was actually looking at the effects of water fluoridation in Birmingham. And interestingly enough, and some of you I think may have heard me say this before, that the dental health of children in Borsall Heath, which is the sort of Hare Hills of Birmingham, was the only health indicator which where Borsall Heath was better than the children in Sutton Coldfield, which is, as Councillor Harrington will know, the Wetherby of Birmingham, although they didn't want to be Birmingham in 1974 in the first place, but they are.
Sorry, Dr. Bill, let me come in here. I'm sure we're going to give you a medal for declaration today, but because Victoria was going to set up, start the paper on water fluoridation, if she can come in and then you come in with your experience, if that's okay.
That sounds excellent, Chair.
Excellent. Thank you. Victoria, over to you.
Thank you, Chair. So Emma and I will do a double act on this one, this Emma Newton. So we were asked by the board to produce an update relating to fluoridation, which is in Appendix 4 of the paper pack, page 43. So I hope that's helpful. And we were asked specifically to understand, to look at the legislative development surrounding these schemes and potentially how this could have an impact for Leeds. So this is what we've done. Because we work with our colleagues over at NHSE, we've worked with Sandra Whiston, who's the consultant in dental public health over there, and to produce this with her advice and expertise as well. I mean, I'll hand over to Emma in a second just to draw out some very brief points, because presumably everyone's had a chance to have a look at it. I mean, in essence, the review of the evidence would still support this as a thing that would make a positive impact on the health of the local population. So that's a sentence summarising the evidence, and there's support there from all 4 UK chief medical officers, which is obviously very strong. The significant thing about the legislation is that it's moving towards a national leadership for consultation on fluoridation proposals, and this was partly to reflect the complexities of trying to do this locally, just because it's with different water catchment areas and different water boards and different local authorities, it was just so difficult to ever get some traction and decision at a local level. So at the time of writing, the draft regulations were still to be approved. At the time of meeting now, they have been signed off, so this came into effect on the 8th of November, so it's very recent and very live. But if we may, just very, very briefly, Emma will just say a few more words about the content of the briefing. Thanks, Chair.
Thank you. So yeah, just to highlight the key points really. So as Victoria said, the water fluoridation clauses of the Health and Care Act came in on the 8th of November, which means that the Secretary of State has to notify local authorities of proposals for water fluoridation schemes that include their population, and that includes the plans for consultation. So in terms of consultation, that would be on a national basis and it would be open to all, but at the Secretary of State's discretion, and a local weighting of responses for the areas affected by the proposal may be applied. And just to highlight, the Water Industry Act does maintain the duty on the Secretary of State to monitor and report of the effects of water fluoridation every 4 years. So just in terms of key points to highlight, as Victoria's already mentioned, water fluoridation is supported by all the UK chief medical officers. It doesn't rely on the behaviour change of people, but does contribute to lower tooth decay. So 5-year-olds in areas with fluoridation schemes in place were less likely to experience dental caries than in other areas without the scheme. Children and young people in areas with a fluoridation scheme in place were less likely to be admitted to hospital, which is a key sort of issue. And then children living in fluoridated areas have lower rates of tooth decay than those in non-fluoridated areas. And the effects were seen in terms of levels of deprivation. In the least deprived areas, rates were seen to fall by 17%, and in the most deprived up to 28%. So we are open to any questions, but we might need to take some questions back to Sandra if we can. So our other colleagues.
Yeah,
in the
thank
room.
you very much. And obviously we did have a little subgroup for water fluoridation a while back, of which Dr. Bill was there, and I was really for it, because one of the things with it, whether you live in a deprived area or you live in an affluent area, we could clearly see a reduction, you know, especially in children. And it's a no-brainer, you know, why we shouldn't embrace water fluoridation. But Dr. Bill, you got PhD in that, so I'm sure you can highlight some more perks for us. Thanks.
Thank you, Chair. Yes, just to reiterate what Victoria and Emma have said. Subsequently, also, the government have announced that the first tranche of new schemes will be in Northumberland, in Northeast, where they already have actually quite a bit of water fluoridation. The city of Newcastle, part of Northumberland, part of County Durham are already fluoridated, and they were in the process under the old legislation pre-pandemic of actually, you know, progressing to extend their schemes. So the government has announced that the first tranche of fluoridation would be up in the Northeast. I think it might be interesting to see if the local authorities, who aren't the final say-so now because the government is, approached the government and said, we're interested in being the second tranche. We know that our colleagues in South Yorkshire had already started on that journey, again pre-COVID. So I think if Victoria spoke to her colleagues in public health in the South Yorkshire health authorities, and also her colleagues in the rest of West Yorkshire, at least there would be a sizable block, and then it would obviously have to go through the process. Both of the local authorities need to be broadly in support, because the government won't do it unless local authorities do support it. But like putting ourselves at the front of the queue after the Northeast.
100%. Victoria, did you get that?
Yes, absolutely. I mean, I guess that what we've been asked to do for the board today is to provide a briefing on both the impact and the legislative developments. So obviously, I'd be interested to hear the views of the board around any next steps.
Excellent. Right, board members, I need you to support this. Yes, Councillor Berg.
Well, surprisingly, I thought I'd play devil's advocate for a minute. Surprisingly. I know Friends of the Earth have got a huge campaign, haven't they, against fluoridation of water. And that sounds based on 4 principles. One, there's the data that supports that teeth are better is unsafe. And by unsafe, I mean it would only be safe data. Don't shoot the messenger. It would only be safe data if you could measure that every single person had had the right amount for their height, weight, blah, blah, blah. But there's no measure that I never drink tap water, so I'm never having any. And somebody else might drink lots. So based on that, basically, there was a whole thing about human rights. So I'm just playing devil's advocate, because if we're going to scrutinise something, it's important that we scrutinise all elements of it, isn't it? And there was a whole thing, and I'm going to do this from memory, that fluoridated water is classed as functional food. That was the term they used. And therefore it was, it needs to be treated as if you were administering a prescription. So it's kind of against your human rights to just give people a drug. I'm not saying that that's my view at all. I'm just saying that that's what Friends of Earth advocate, and quite a lot of groups who are against it. So I think it's only fair we kind of put that out there and give people a chance to respond.
Yeah, definitely. I mean, I don't think anything will go out without consultation. So as a city, and definitely Victoria, I know that yeah, just can we take questions, and then at least you can respond to all of them. Yeah, so over to you, Councillor Hatbrick.
I think since we're playing devil's advocate, I'll go for a devil on the other side, whether that makes me a devil or an angel. Yeah, I mean, I think clearly it is a health intervention. as was the COVID vaccine, which I know was controversial, and many other health interventions. There are other health interventions that nobody talks about, such as adding vitamins to flour, which again, technically turns them into a functional food. Nobody even really thinks about it. And I think, I think there was a minister many years ago that said we've had enough of experts. I think as a country, we need more experts. And actually, the expert opinion is pretty clear in that fluoridation has vastly more benefits for public health than any minor conceivable downside. So I think it's right that as a city, we should consult and ask our population, which is the way to go. But I don't think we should go for the kind of false equivalence of rumor, conjecture, hearsay, whispers, whispers in internet forums, which kind of give false credence to myths and rumors, which are misleading and actually detrimental to public health in a world where actually the science and the data, in fact, even with people doing PhDs in it, seem pretty conclusive. So I think it's a debate that we should have, but I think ultimately the evidence should win rather than any sort of emotion.
Many thanks, Councillor. Councillor Anderson.
Thank you, Chair. I don't know how many other people had this at school, but we used to have the fluoride lady that used to come round every fortnight with her little cups of pink fluoride with a big bucket that we used to have to swish and then spit out. Now, being a child, I never really thought about what's the outcome of that. But I do remain to be convinced on fluoridation because most water that we use is not for drinking or cleaning teeth. But I accept that if it has a proven beneficial effect on children's teeth, and that's what I've been complaining about this afternoon, then, it is definitely worth having a consultation and worth having worth discussing.
Thank you. Dr. Bill now, and then Councillor Burke.
Not a lot to add, apart from the fact that it's not a magic bullet and it doesn't replace any of the things that Emma was talking about. They still need to be done. It is an addition to the what they are already being provided with. So in Birmingham, they don't stop doing all the other things that Emma's talking about in Leeds, but they have the additional benefit of the water fluoridation. So it's very important that it's part of a palette of things to do rather than one silver bullet.
Thank you. Councillor Bragg.
Just wondered if anybody could comment on the health problems linked to fluoride ingestion, skeletal weakness and again, I'm not an expert. This is just things I've read. You've got to, and this is from NHS website, not my words. And that overexposure can cause real problems. And I just wondered, because we can't possibly measure how much individuals get, how we would, and does the benefits outweigh the risks even?
Thank you. Mandy, and then Victoria, you can summarise for us, please.
The public has got a bad, my age group fluoride's got a bad rap because of World War II and Germany using it to give to the prisoners to keep them subdued. And vitamin D is more important. And we took that out of our flour, out of our butter, out of our milk back in 2012. It was called the Codex Alimentarius and it went across Europe. That's why Marmite was banned. Thank you.
Thank you, Mandy. Victoria, do you want to come back now?
Yeah, I think it's important to say that what we've done in the briefing is summarise the latest national advice and the summary of the most latest evidence around fluoridation. So we absolutely would take a position of reflecting that very latest and current position, rather than come up with our own sort of view of the world. So what's not being proposed is our personal view, but it's a summary of the view from all 4 chief medical officers are on the balance of the very latest evidence. Now, we all know, and particularly from the last 2.5 years and much before, that that there will be a range of different views of people around any interventions which bring kind of additives or unnatural products into people's lives, and that's absolutely legitimate, and we wouldn't we wouldn't want to kind of control that in a way that doesn't hear that. I mean, I think all of our learning from COVID really reinforces that we've got this range of views, and we have to support people and respect people's choices around their own health. So I think any approach that we take would need to completely balance the voice of people and the rights of people to hold strong views across that spectrum, and not to brush those under the carpet. But we would always want to reflect the latest advice around harms to health. So our reading of the latest advice and the current position of the chief medical officers is in all of the review of all of the scientific evidence, the benefits to health outweigh the harms to health, which that certainly the narrative around the level of fluoride in water is so tiny and so low that there are in their opinion no harm to health from it at all, not a small amount, but no harm to health. So what I am really keen to do with all of our partners is to ensure we reflect that latest position, and take the view from national and international experts on all of the evidence, because we're here for the people of Leeds, but we need to rely on local experts in this field. So I think it's important that from the board conversation, I share that approach around always reflecting the very latest evidence from national and international experts, not kind of coming up with a kind of a version of that suits what we may want to do. So we'll continue to reflect that position, Chair, going forward.
Absolutely, Victoria. Thank you very much. I'd like to hear from the dentists themselves on their reflection on fluoridation, please. Thank you.
Well, speaking as a clinician, I can just reiterate that there's absolutely no evidence of any harm caused by fluoride whatsoever. And one thing you need to remember is that fluoride exists in natural water supplies as a trace element in a lot of areas anyway. So we have plenty of areas where fluoride occurs naturally in the water. So if there was any evidence of any harm to people, it will be concentrated in those areas, and there is absolutely no evidence whatsoever. And it is a tremendous benefit, especially to the children and the vulnerable that we have been talking about and wish to direct our preventative services to.
Thank you, Jane. I got your name right. I did call you Emma the last time. My apologies. So thank you. Yeah.
I'd just like to agree with Jane with fluoride. If there was an issue, there'd be a lot more sick people in Birmingham compared to Manchester, where the water is fluoridated, and statistically there's not much different, or no difference. Also, we had a patient who used to always use a fluoride toothpaste. She came in, one of our dentists saw her, all of a sudden about 15 of her teeth had decay. And then when we did a full history, she'd read fluoride was bad for her. So a year and a half, 2 years previously, she'd stopped using fluoride toothpaste, and she thought it'd be better to do a coconut oil rinse or something in her mouth. And she's ended up with a lot of decay and problems. And I think it's all down to her stopping the fluoride that she was using previously. Okay.
Thank you very much. Sorry, Mandy, because of time, I would really like to hear from Emma and Ian on what has been discussed today regarding fluoridation. Obviously, we would like to, in terms of from a commissioner's point of view, what actions you will be taking away from today.
Sandra Whiston that Victoria is in our team, and we're receiving a briefing very much in line with this next week. So I think at that point we will be having some discussions with our ICB colleagues to reflect on that position and agree, because obviously this is a longer term view, isn't it? It's not something that's going to happen over the next weeks and months, so we need to make sure that we're working as a system. I think part of the challenge for us as NHS England and commissioners has been we haven't always been able to work in that system. Some of the challenges around engagement with water boards, etc., has been a challenge, and I think it was Dr. Bill referenced our South Yorkshire colleagues. I think they have some quite big challenges to share with us that we can learn from in terms of trying to engage with our systems. But given that it's a longer piece of work, I think for us in NHS England, it will be making sure that we're aligned with our system and can do this as one voice, because as we've already heard, there are many views and many reference points.
Okay, so generally what will be the takeaway from today is the specifics that we would like to know, if that's all right. Emma or Ian?
In terms of fluoridation?
Yeah, and generally.
Oh, generally.
Yeah, from agenda item 7.
I think it's been incredibly helpful, certainly to have the patient voice and to gain some sense of what I think we already knew in terms of the challenges for our system, not just, and sometimes I think we can get quite focused internally, so it's really important that we do work with our systems. So I've very much heard, I hope we as a team have very much heard the system. I've written notes to make sure that we can pick up on some of these things. But I think one of the things that I'd really like to tangibly take and be able to be held to at the next meeting is how well we've engaged with our patient voice and our users. And we'll certainly work with our Health Watch colleagues to focus on that and think about how we can do that. I'm really keen that we do that as part of our general system, not wait for things not always to go quite so well before we then start to get that feedback. So for me, it's very much about making sure that the patient and service user voice is part of our reflection and using it alongside the evidence.
Okay, thank you very much, Ian.
Yeah, I mean, just to agree with Emma, I found it a really helpful conversation. I think bringing the groups together around the table to have this discussion has been really powerful and really helpful, and particularly thanks to Mandy for sharing her story. I mean, I'm taken by what John said at the start of his comments, which is actually we've been dealt a pretty difficult hand on some of this stuff in terms of the contract, the funding, the workforce pressures. But what's also clear from the conversation is there's stuff we can do differently and stuff we can do better. I think some of the communication stuff clearly needs to be improved. I think the way we work with Health Watch and other partners to build citizen insight into what we do can be a real strength of the way we work. There's loads we can do around preventative services across West Yorkshire using the examples that Emma's given us. I think we need to have a look at the point around folk getting kicked off lists if they miss one appointment, because clearly that's not right and shouldn't be happening. So it has been really helpful for me to sit and listen. I think we need to be realistic about what can be achieved over what timescale, but there's some really good practice and ideas that I've heard that we can absolutely take forward.
Okay, thank you very much. I mean, we all can agree that it hasn't been the easiest of discussions, and Mandy, again, very proud of you and thank you so much for your of course. Yeah.
So a lot of people in my age group, they just think that's right wrong. That's one.
Yeah.
They went out in the 80s.
Yeah. Thank you. And thank you very much, Stuart. Thank you to each and every one of you who have contributed today. And obviously we will be in touch with yourselves, obviously, in terms of updates, and hopefully in the new year, we will have another better meeting with more positive impacts on what you've done and taken away from today's meeting. So thank you very much from all of us. I'm not sure if you're all staying. Feel free if you need to stay, but if not, we're cracking straight on to agenda item number 8 now. Sorry. Of course, yeah. So agenda item number 8, Leeds Health and Care System Resilience and Winter Planning. So the Scrutiny Board has previously maintained an interest in the Leeds Health and Care system resilience and winter planning process. And so we have requested, the request from the board today is that a briefing paper has been provided by the Leeds Health and Care Partnerships, which sets out the issues and actions linked to the current process. So I believe we've got Shona, Helen, and Mark. So you just introduce yourselves. I'll give you a minute. Actually, you know what? Let's have 2 minutes break, everyone. 2 minutes. I'll be right back. Okay, we're ready to start now. Shona, would you like to introduce yourself and Mark as well? So whoever is working on this agenda, please just kindly introduce yourselves and then we can start.
Hello, everybody. I'm Shona McFarlane. I'm the Deputy Director for Adults and Health. I manage social work and social care services. Thank you.
Good afternoon, Chair. I'm Helen Lewis. I'm the Director of Pathway Integration for the City, for the Integrated Care Board in Leeds. And I've coordinated the paper today. Sam's just getting her teeth. I'm going to introduce Mark.
Good afternoon. I'm Mark Dodd. I'm the Deputy Director for Service Delivery at Leeds and York Partnership Foundation Trust.
Thank you all for coming. Okay, I believe, Helen, are you the one leading on this paper? Over to you.
Thank you, Chair. I'm conscious that colleagues have had a long afternoon already, so I'm going to propose, if it's all right, just to describe some highlights. Chair had kindly invited us to come back, as we normally do at this time of year, really just to describe the approach that colleagues are taking to manage and prepare for the winter period across health and care. We've included elements from all provider partners, from public health, a section around vaccination. And what we've tried to describe is how we work together as a system, a series of the actions that we are taking, a section on the risks that we face and what we are trying to do to mitigate them. And then really to give colleagues on the Scrutiny Board a chance to ask any questions they have about any of the areas of demand that we've described, any of the areas of capacity that we've described,
or any questions and concerns that they have. And I'm joined by system colleagues who are all expert in this arrangement. Apologies from Leeds Teaching Hospital colleagues who had a winter planning event at the same time, but I'm happy to try and answer the questions on their behalf if necessary, or if not, I can defer and ask them to come back to members, so however people would like to do that. So rather than running through the paper again, I think it's probably easier just to go straight to questions. I hope the paper is relatively clear and self-explanatory.
Okay, thank you very much, Helen. I'd just like to ask the exec members of Victoria if you would like to add anything before board members come in.
Just to say, this is obviously an area of really grave concern for everybody, and it's been fairly terrifying, the state that we've been in this autumn. We're not in winter yet, so this planning is really important, and it's important that the board has cited on it. Thank you.
Thank you, Councillor Venner. Okay, board members now. Yes, Councillor Hadbrook.
One specific bit, just a anecdotal observation, really. The vaccination plan this year, based on my own experience and what I've seen kind of happen in my own ward in kind of Rothwell and Alton, seems to have started earlier with stronger communication and more vigour. Now, I don't know whether that's just my snapshot experience or is that something that's replicated, because it feels, from what I've seen and from what I've seen in social media, it feels as though we've got to be more proactive and engage more people earlier, hopefully with good results.
Thank you. So I would say that locally we have been able to get more communication out, more social media out. I think if I were to make a criticism, the national comms have just been a little bit later than we would have wanted this year. But as soon as we had vaccine available, we were out vaccinating and making sure that we were getting to our target groups. We've got comms leads on the vaccination steering group, and they're looking at how we can increase uptake in the areas where uptake is less. So I think it's a constant challenge for us, but one that we're embracing.
Thank you. Are you happy with that, Councillor? Yeah. Yes, Dr. Bill.
Thank you, Chair. Just to pursue that with you, we learnt a lot about vaccine hesitancy during COVID. Are we making any special efforts this time to actually use some of those things that we found worked to increase the uptake?
Absolutely. We're learning all the time. What we found it was really helpful was to get out to local communities rather than expecting them to come to us. So we continue to do pop-ups. We continue to go to areas of high footfall, such as shopping centres and so on. We have a cultural diversity lead who works within the programme, looking at how we can best engage with different communities. So we continue to do that. We also have worked in the hospital, looking at working with ladies. That very active campaign, and we're looking all the time to improve uptake.
Very reassuring.
Thank you very much. Victoria, is it Councillor Arif? All right, both of you. Okay.
Thank you, Chair. Yeah, Dr. Beale's question and Conrad as well. Thanks for that feedback. That's really good and that's really important. I think from our perspective as well, from a public health perspective, it's important to learn the lessons we did learn in the last couple of years, but actually not stop there and actually make sure that we carry on with the work that was being done, just picking up locally. And anecdotally as well, in terms of access, you know, we're still at the fire station, we're still at local Bilal centre. There's all of that work still happening and communities are picking up on that. So just really thank you for that as well, for all that work that's going on. It's really important. Just because we've moved on from it, there are still very vulnerable people out there that definitely need the vaccine, and particularly with the sort of double whammy of flu as well. So I know I had with the Lord Bay and Victoria, we had the flu jab and also the COVID, and we made sure we did the comms around that because it's important, particularly to get the message out that we're getting the vaccine. It's important and encouraging local residents to do. But yeah, just sort of to reassure you and the board that that work is very much still on our radar and it's still happening. Thank you.
Excellent. Thank you. Victoria.
Yeah, very briefly, Chair, just to add to Sam and Councillor Arif's comments. I think there's a couple of things this year which we're very mindful of. I mean, on a very positive note, in Leeds we have the No One Left Behind programme, which Sam's leads closely with other colleagues, including public health colleagues, and we're really proud of that. And it's something, as Councillor Arif just said, that we've got learning about going out to communities, working in different ways, doing everything we can to reach the people we most need to reach. And we have got quite a lot of recognition for the Leeds work, kind of nationally and regionally for that. So we're very, very committed to keeping that going. But there's something about moving from the height of the pandemic, when this was the focus of everybody's sort of attention, to the fact that people are often busy with other things now, and this is more of a business as usual thing. So there is a challenge to how we keep that going as business as usual. I think it's fair to say that in terms of the hesitancy question, the way that we apply our work now has changed because the offer has changed around vaccination. So a lot of the groups who are more hesitant were often in, for example, younger people. Now, lots of younger people aren't eligible anymore unless they've got a clinical reason to be. So there's a slight change in terms of making sure that we target the people we really need to come forward to minimise health harm and to protect the NHS, which are often older people and people with a clinical condition. So that's a change in the message from we want everybody to be vaccinated, which was the case in the height of the pandemic. So I think there's something about complacency of some of those at-risk groups we still need to vaccinate. So generally, and Sam carries all of this detail in her head all the time, but generally we're doing pretty well on the older age groups, and we're doing less well, for example, with pregnant women and younger people with a clinical condition. So we're still sort of looking at that with all of the groups that we absolutely still need to get to, but it's not the same as the kind of en masse work that we did in the middle of the pandemic. But loads to go on there, but it's just keeping that messaging as the programme changes and stopping people from being bored of it. I think that's the challenge. Thank you, Chair.
Thank you very much, Victoria. Councillor Harrington.
Thank you, Chair. It was just a question, it's kind of linked to that, Victoria, actually. That I've noticed in our area, a lot of the pharmacies are doing flu vaccinations. So it's a standalone flu vaccination. But the doctors, my surgery, for example, I'm having my jabs next week and they're going to do the joint ones. So I'm kind of wondering why pharmacies are offering to do flu for the same age groups that we're talking about doing the dual vaccination for, because it's a bit confusing. And then I'm also aware that several residents have still been going to Harrogate and York to get the COVID boosters by booking on the national system. So I'm a little bit confused about what the message is that's going out, because in our area that seems to be a bit contradictory. And I'm also interested to know of that sort of older age group, are a lot of people not having it because they're concerned about having the two together? Have you had that kind of feedback? Thank you.
Okay, so all PCNs are requested to be part of the programme, and all the PCNs have opted in. There are some practices that have not in the PCN areas, but all PCNs are vaccinating. Community pharmacists can then apply to be part of the project as well. And so people can take a choice as to whether they go to their GP, they go to a pharmacy, or they go out of area. A lot of people, I think, look to see how can I get this the quickest date possible. So looked online and booked a date that way. But there is a local service for every local person, but there's choice as well. Does that answer that question? Yeah. Oh yes. Why some doing flu only? Again, choice. They can do both. And the question about is there hesitancy because people having it together? You can choose. You can have one at a time or both together. I think we have picked up a little bit of hesitancy about I don't want them both on the same day. And we've also had, if I've got to choose one, I'm going to choose flu or I'm going to choose COVID. So we continue to work on it is the honest answer, and try as much as possible to have local services for local people.
Thank you. Yes, Councillor Henshaw.
Thank you, Chair. I was talking to a gentleman in sheltered housing yesterday who'd been and had one of the jobs himself. And when they turned up at his house or his bungalow, he told them that. So they said that they couldn't give him the other one. He'd have to make another appointment at his GP's. So he's had to make an appointment at his GP's to go up and have the other one in a few weeks' time. And I just didn't know why they couldn't give him just one of them.
I can't really work out what's happened there. I'm wondering whether, I'm presuming that you're saying that he'd had maybe flu in one place and they went round to do COVID. And if that were the case, they could give the COVID. But I can't quite understand why there's been a problem. So it's probably one of those things that if you want to talk to me afterwards, I'll look into it as an individual case, but there's no reason why, if it was recorded on the system that one had been given and then someone came to give the other one, that they couldn't have had it. So tell me about the detail. I'll look into it for you.
Thank you. Dr. Bill, did you have your hands up? You didn't, right, earlier on? No. Okay. I would like to ask Mark, from your own perspective, are you able to highlight any issues at the moment? Thank you.
From a mental health perspective, obviously we're facing immense pressure as the rest of the system are. Staffing is a particular issue for us at Leeds and York. We're doing everything we can to recruit and maintain our staffing. We're planning for the winter. We know that we've got an immense amount of pressures ahead of us in winter. The demand on services, we're seeing quite a high level of need within our services. Struggling with staff. Our staffing at the moment, in terms of the flu and the COVID, we're doing really well. We've had a good uptake with the vaccinations, but as we move deeper into winter, we're not sure what's going to happen there really. We are seeing, as I say, a high demand on particularly patient beds, and we are using an increased amount outside of Leeds, a number of beds outside of Leeds. It's something we're loath to do, but we know that we have to, but we are having close monitoring on those. We've got a team that monitors those placements. Yeah, and I guess we're just planning all sorts of measures to get us through winter really.
Okay, thank you, Mark. You've got a question for Mark?
Yes, thank you, Chair. Just very briefly, when you say patients are being sent outside of Leeds, obviously, I'm sure we all appreciate kind of current bed capacity and staffing issues. There are obviously a number of stories that have been circulating within the media, some real horror stories in terms of kind of patients being sent from one end of the country to another purely to deal with capacity. How far are we sending people outside of Leeds? Is it Yorkshire wide or further afield?
It does vary. Mostly we try and start within the Yorkshire region, but we are usually we've commissioned some beds up in Darlington, so in the north of Yorkshire, but we have sent people quite far afield on very few occasions, but we prioritise them for coming back into areas as soon as possible.
I think it'd probably be safe to say as well that depends on the level of need. So if it's a psychiatric intensive care unit bed where there are fewer of them, then people might be more likely to have to go further. Whereas if it's a more general bed, there will be sometimes at least more of a choice, and colleagues will always choose the nearest possible bed. So I think it is that. I think Mark's just mentioned that booking, sorry, it's been a long day, booking a group of beds in Middlesbrough. One of the reasons in Darlington, one of the reasons we want to do that was so that we can make sure that we look after those people with an outreach team so that it's easier for them to feel that they belong to the system, that we've got access to their notes, we've got access to their home social workers, and that makes that length of stay in out of area as short as it possibly can be. So that's always our priority, to find a safe placement, but then to bring those people back as early as that we can. It's harder with psychiatric intensive care, as say, Mark, and the higher the level of the need.
Thank you very much. Whilst we're still talking about mental health in reference to that, obviously from page 58 and talking about the risk, the pressures on mental health is still very high. And earlier in the year when we were discussing mental health, I do know that mental health were having problems with referrals from GPs in terms of expedited letters and things like that. And then obviously we were, the GPs again, were also getting referrals from the hospitals that have been referred to the GP back to the, to the hospital, back to the GP. How are we out with that? Thank you.
It still remains a pressure for us. We've adjusted the way we operate in terms of the way we receive referrals. We've had considerable pressure for our community services through, well, since November of last year. They control the single point of access, and we've moved a single point of access so we can be more responsive. We've put in measures, a triage system that we can deal with referrals more quickly and prioritize those with a higher level of need. We sit that within our crisis service now, and being able to respond to those with a higher level of need more urgently as well. So it's far from perfect, given the pressures we have and the staffing we have, but we're constantly reviewing it, and we're adjusting things as we need to be able to respond to that need.
Thank you. Yes, Councillor Burke.
Thank you. Can I just ask how you are perhaps linking up and interacting with the mental health transformation service, because I think it'll do exactly what it says with the package, and the community connector teams, which will obviously hopefully reduce people ending up at crisis. Thank you.
So our community service, both for adults and older people, are very much part of the transformation programme. We're also looking at other areas, diagnostic areas for particular patient groups. So we're very much part of that transformation project. We've got senior staff within those areas working alongside the transformation team to progress some of that work. We recognise that is a significant change for us, and for the positive, really. And we know that it's a direction of travel that we want to take, and we sign up. Obviously, with everything that's gone on over the past couple of years, it's stalled a bit, but we're aiming to get back on track, and a lot of activities occurring around that.
Thank you, Mark. Councillor Farley. Oh, sorry, Sam.
Can I just come in about the primary care mental health and Leeds mental wellbeing service are all part of the mental health transformation as well. I think it's a real opportunity for us to bring it all together so that we don't have people falling through the cracks and we're working as one system.
Sure, thank you. Okay, yeah, Councillor Farley.
Thank you, Chair. Do we have anybody from LTHC here? No.
No, but I'm happy to try.
Okay.
I'm happy to try their help. I promised I wouldn't represent, but tell us what it is, and we'll either answer or
thank you. Yeah. So obviously, as we go into winter, I suppose we didn't really leave winter 2014 across the system. I suppose the big issue is always, as ever, is delayed transfers of care and kind of getting those patients kind of through the hospital system and back into either a home environment or into a intermediary or community environment. So that obviously resources and limited resources within the hospital environment and acute environment are not being used up. I suppose my question for anybody to speak on behalf of the acute sector in the city, and I suppose to both council officers, is around what systems are in place to ensure that kind of patients aren't bed blocking, and how have we smoothed up those processes?
Okay, this will be quite a comprehensive answer, so get ready, I suppose. I think the most important thing is for us to always consider admission avoidance first, so that we can provide support to people before they actually go into hospital, and then they less likely to decondition in hospital and need heavier levels of care coming out. But once they are in hospital, we have a transfer of care hub, which is a joint service that's run by myself and Shona's team. And we look at how we can get people to the next place as quickly as possible. So we've looked at streamlining processes, and I think that we're well on with that. But we've also looked at how do we ensure that we've got the right capacity in community services to get them out. So we have had some investment this year in terms of increasing the number of night sitters that we have, because often people are left in hospital because there isn't someone to see them 24/7. We've had increase in therapy budgets so that we can have more therapists that are working on their independence and making and rehabilitating them quicker. And we have more investment in self-management. So lots of people often leave hospital and they need some kind of low-level intervention, but we could actually teach people to do that themselves, hence improving their independence as well. So I'm really proud of that. And at some point when we have time, I'll talk about the outcomes that we have got with self-management, because they're phenomenal. And then we're also working together around active recovery. So the reablement service that's provided by the council and our neighbourhood teams provided by health work together to try and get people out of hospital as quickly as possible. Again, with a real focus on getting them home rather than into long-term care, and a real focus on rehabilitation and independence. So I think that we've made a step change from last winter to this winter. That's not to say it's not challenging, but I think that we have made that step change. I've just looked at Shona, do you want to add?
Thank you, Sam. We're seeing a sustained improvement in the ability of our home care services to pick up packages of care in a timely manner, and that's helping enormously for those people who do need a package of care when they leave hospital. We prioritise the hospital for any packages that are required. We've also implemented this year a bed brokerage service, which has started to impact on the pace of time that it takes to get somebody from where we identify they need the long-term care service to the point where they're in the home that'll meet their needs. We've done that through developing a bed brokerage service, which is developing better relationships with the care homes, reducing the number of people that are ringing them every day, and targeting the right home for the right individual. So those two things have been extremely helpful, in addition to the items that Sam's just mentioned. Thank you.
Thank you very much, Shona.
Probably just worth adding that in terms of assurance, I think it is absolutely the area that we remain focused on, because we know that people, we will try all we can, and I think our diversion work is really paying off. Our admission rates have not been significantly higher, but they've been lower than in some previous years. But we do know that people who do come in will be slightly sicker, slightly later if we have a bout of flu, or we have people just generally more unwell as they come into hospital, partly because we've diverted the people who are able to be diverted, which means the people who are in are sicker. But we have a very, very strong focus on it through all of our governance structures, and all of the actions that we've identified, some of which are described in your plan, include that continued tightening up, so that we look for every opportunity to reduce the delays. I mean, they're small things that can make a big difference if you multiply them over lots of people. So we've invested very heavily in more ward-based staff to really just be on top of that. We've reopened a discharge lounge to encourage, so that people can sit out in the morning, so that if there is someone to come in, that we can try and find those people at bed most appropriately. And we continue to do everything that we can across that. So our winter plan that we've described just in very brief detail in the paper is focused on increasing capacity and flow for people with no reason to reside, so that we can free up those beds for people with an acute need. So that is the sum total. So it's some additional beds for acute capacity, but by and large, what we've tried to do is invest in alternatives to hospital, so that those people can then move more quickly, and continue to look for any opportunity to reduce any delays. So in the ongoing care, so the home care work has been really, really helpful in that, and the work that Shona's also Shona's colleagues have invested in some more capacity to just try and get on top of some of the delays that we've had over the summer due to vacancies in all parts of the system. So we're really consolidating over the last 4 weeks and more to do, but I think there are some glimmers. I think the difficulty is because the pressures are so significant, it's sometimes hard to see the improvements and the counterfactuals. So that I know that it would have been worse, but it doesn't actually feel great if you're sitting in an A&E department with too many people in it. To say it would have been worse feels, it's not a very encouraging thing to say to staff who face those pressures every day. But there definitely are improvements that you can quantify. It's just there are other things coming the other way, which is why all systems everywhere are under significant pressure. And we are certainly not alone and probably not the worst in percentage terms. It's just a big system. I think it's probably also just worth reminding Scrutiny colleagues that LTHT in particular has always prioritised ambulance transfers, because we're very mindful as the biggest player that if we delay patients, it has a massive impact on the whole of the rest of the Yorkshire Ambulance Service handover times. So our handover times at LTHT are significantly lower than the national average, and that's really important to us, but that's not without pressure on the A&E department. We've made a system choice and the providers made a real strong choice to do that, because the knock-on effect for people and someone in their own home then waiting for an ambulance, we've made a judgment that at least in an A&E department or in another area in a hospital, they have some oversight. Whereas if you're on your own waiting for an ambulance, you have no oversight. So it's important, I think, that Scrutiny is cited on that, because that is one of the things that we do. It's a balance of risk, but we've made that judgment as a system to prioritise ambulance handovers because of the knock-on effects to, well, our residents, but also the wider West Yorkshire and Yorkshire Ambulance Service residents. So I think that's another pressure that sits in our A&E department, which obviously is not ideal for the experience of patients in those departments, but is certainly improving the response times that otherwise people would otherwise face when they're waiting for an ambulance at home, which is probably the most stressful thing any of us ever do. So I just think that's probably worth adding in.
Thank you very much, Helen. Back to you, Councillor Farley.
Sorry, you're absolutely not going to be able to do justice to the couple of quick questions that I've got here. Firstly, it's great to hear about obviously kind of working together and partnership working between the organisations. That's really positive. I suppose my first question is thinking about the workforce and how we are how different roles are being utilised across the system. Obviously, we've got some amazing doctors and nurses, but we've also got our fantastic AHPs who do a remarkable job in terms of helping people to get from hospital back to home. So how are those roles being utilised? And obviously kind of new roles, well, newish roles, for example, like advanced nurse practitioners, etc., within the ED. My second question is, what safeguards are in place to ensure that we're not discharging medically unwell patients? Now, I'm playing devil's advocate here because I appreciate that there will be safeguards in place, but I just want to give you the opportunity to respond to that. So workforce and chucking people out.
I start on workforce then. So I think the roles that I've previously talked about in terms of self-management, that's not a registered role. It's getting people to be very competent in regular procedures and then teaching people. So that's something quite different. And it also brings in a new workforce. In terms of therapy, I think you would see therapy at every point in the whole journey. Particularly proud at the moment of the therapy supported discharge, which is working between hospital and community, making sure that the journey home is as easy as it possibly can be. Just wanted to raise awareness about another project called Enhance, and what we have found as someone working in community, previously, we wouldn't have been able to discharge people who perhaps needed the care of a relative, just to keep an eye on them. So not to provide any clinical input, but keep an eye on them. And we have commissioned the third sector to act essentially as proxy family. And that's been, we're just getting an evaluation of that at the moment, and has had some amazing results. Can I indulge you in an example? Okay. So we had a gentleman who was lonely, and he was ringing for an ambulance on a very regular basis. By the time the ambulance got there, he was perhaps intoxicated, and the ambulance didn't know what to do. They would bring him into hospital. He was staying overnight, going home the next morning. And basically, the Enhanced team went to talk to him, and he said, I hate Saturday nights. I'm always lonely. My family have gone. And now they have a regular 15-minute contact with him on a Saturday afternoon to keep him straight. So I think it's 12 weeks now that he's not called an ambulance. And that seems like really petty, doesn't it? That just a really small intervention made a complete difference to him. But also, if you look at the resources that are saved from doing that, it's incredible.
Thanks. I think if we'd speak to the other roles, I think Mark referred to them earlier, and Councillor talked about the community mental health transformation. We are working really closely with third sector staff, I think, across all of our pathways. I think the other work, and Shona may want to add, is how we support registered social workers in doing registered social work tasks by finding some of the others, the information gathering, some of the talking to families. So we have support from Carers Leeds, we have support from Age UK, we have support from the care home trusted assessors run by the Leeds Care Association. So we have other colleagues who are helping with some of that process stuff and talking to families to try and meet some of the challenges that we know that the Health Watch report identified about how we really support people through discharge and help people feel that it is a process where they're supported rather than kicked out, which I think speaks to your offer. I think in terms of whether we're pushing medically unwell patients out, I think one of the things that we do with our Transparent Care Hub is really evaluate what's the best place for that person, and some of that dialogue then that we've now put into that process will then actually go, well, actually this person's not ready to go home today, and sometimes we'll have found a placement for somebody and actually something has changed, and so I think that level of engagement back with the ward staff to go, well, we have got somewhere for them, are you sure they're ready to go, then creates that challenge. We do know that many of the people who the national definition of no reason to reside is somewhat different from some of the medically optimized words that we've used previously, and they have changed the threshold. So, you know, you can be still relatively unstable, but not meet those very strict criteria. And I think we are seeing then that people are trying to encourage people to move to another setting earlier than we probably would have done 3 or 4 years ago. I'd be interested in Shona's view on that. And so I think inevitably some of those people then will not necessarily manage to stay in their new setting. And that's a balance that we juggle every day. The balance of actually, are you just creating churn in the system, or can we provide the appropriate level of support for those people to be managed? And I think that's a judgment that we probably won't always get right every day because of the pressures, but I think it's a really good challenge to us, which is our readmission rates haven't gone up, but if they had gone up, that would be a real concern to us. And I think monitoring readmission rates is really important, because that would suggest that we're getting it wrong. I think more often we find a package for someone and then we waste the package because the person's actually not ready. I think that probably happens more often than an unplanned readmission. But again, people are frail, I think would be. Shona, did you want to add to that?
Thanks, Helen. The community care hubs, which we run 3 of in partnership with Leeds Community Health, they're called the recovery hubs. They support people on their journey home from hospital. And we have noticed in the 5 years that they've been commissioned that people are coming to the service less well than they were previously. They're taking longer to recover. They're perhaps needing a bit of time to feel better before they're then supported to develop their therapy activity. So they're spending longer in those homes as a result of being less well. That's not suggesting that that was an unsafe discharge. It's saying that in general, those people have been admitted, have been treated, are being discharged and are less well. They're probably older. They may have experienced the impact of COVID. There's a range of reasons why, but they're certainly staying longer in those homes to the point where they're able to get better and then get back home. So I think that supports what Helen was saying. Similar, I think, in our reablement service, people have been less well and have taken longer to start their recovery journey.
Okay, thank you very much, Councillor Farley. Maybe you missed it earlier. LTHT are unable to be here today because at the same time they're also having their winter resilience planning meeting, and all the directors and heads are at that meeting. So Helen has done a very good job today in helping us out with some of the answers that we need. Victoria, would you like to come in? Yeah.
Thank you, Chair. It was just a brief broader point around the content of the plan and how it joins up more broadly across the city. So what we've done with colleagues is ensure we've joined up the activities across health and care services with some of the work that we're doing out in communities to keep people well and supported well through the winter. Some of this is captioned on page 54 in the public health plan bit, but it was just sort of bringing that to the attention of the board that, as well as the admission avoidance work that Sam's briefly described, we want to go even further upstream into prevention and making sure we do the things that keep people out well and out of hospital, and obviously ultimately avoiding poor health and sadly the excess deaths we see in winter. So there's four main parts of that. One of them is about being really proactive in preventing and managing disease and infection, and particularly in our highest risk communities. So all of the work that still goes on with our infection prevention and control service, working with care homes and other vulnerable residents, we do keep outbreaks to a minimum and very low. So that all helps keep people well and reduce pressure on the system. The second area is supporting people living with frailty through the winter period and other clinical conditions that make them more vulnerable. So we know by being proactive, and there's some examples of some of the programs that do that, which I know as members you'll be very aware of in your own communities, and just what a difference that makes to keep people supported through the winter period. I think particularly relevant this year is doing everything we can and increasing our activity to reduce the harm of cold. We know that all of the evidence suggests that cold is the biggest potential harm to health through the winter period, and with the pressures on heating costs this year, we know that we face extra challenges. So that's very important, and cold and damp together are, the combination is very harmful. So there's increased work on that this year with housing colleagues and others. And then finally, and going back to the point about mental health, looking at the impact of the cost of living pressures on both physical and mental health. We know that when people worry about debt and not being able to afford, basics, we can see a pretty clear impact on both their mental and physical health, and how that plays out into services. So just to bring to the attention of the board, we've worked really hard with Helen and colleagues to make sure that it's joined up as a city plan, not just a plan for our health and care services, who are obviously at the heart of it. So I hope that's helpful. Thanks, Chair.
It's very helpful, Victoria. Thank you very much. And I do know within our communities, lots of the different activities, keeping warm centres and all of that going around to make sure, especially our vulnerable people, are kept safe and warm in these very difficult times. And we do take note of all the risks that have been mentioned on page 58 as well. And we can only continue to ask that, and welcome your resilience, and as well as the planning, and hoping that we continue to show as much compassion as possible to our residents at these very difficult times, and focus on the good as well. It's a lot easier to dwell on the negatives, but we do have some positives going on around in the city in making sure that our residents are healthy and they are kept safe. But at the same time, we do not want to shut our eyes on what's going wrong, and that's why we're here, to be critical friends to each and every one of you. So I just want to use this opportunity to say a huge thank you on behalf of the board, to Teaching Hospital, to our officers, exec members. It's been a very long year. It's been a very tough year as well, but our resilience has brought us to where we are. We're all alive, and we will keep fighting, and we'll keep going. So I will just call on our principal scrutiny advisor on agenda item number 9, just before we close.
Thank you, Chair. Yes, this final item relates to the board's work schedule. The latest version is set out in Appendix 1. as we've referenced in the covering report, but just to point out, in terms of the item that was around liberty protection safeguards, the board had previously been advised of the intention nationally to replace sort of current deprivation of liberty safeguards with a form which forms part of the Mental Capacity Act with liberty protection safeguards. So it was suggested it would be helpful to bring a report back to the board to discuss the implications of this change. This had been scheduled for the board's February meeting. However, the chair had sort of recently been advised of further implementation delays nationally, and so has agreed to remove the item from the board's work schedule until we can have assurances surrounding the implementation timeframe. And then with regards to the budget working group, this has now been confirmed for 14th of December at 4 o'clock. It will be a remote meeting and members should have already received the meeting invitation. Thank you, Chair.
Thank you very much, Angela. I believe just before I end, any other business? Yes, Councillor Farley.
Thank you, Chair. Just a very quick bit of AOB. As I'm sure some of us will be aware, Julian Hartley, the Chief Executive my apologies, Sir Julian Hartley, Chief Executive of Leeds Teaching Hospitals, has been appointed to be the chair of NHS providers. And I understand that he'll be leaving Leeds Teaching Hospitals. Therefore, I was going to suggest that perhaps as a board, we pass on our thanks to Julian for his service to Leeds Teaching Hospitals and his service to the city. I think he was appointed in 2013, so maybe 2014. So it's about seven or 8 years that he's been there. And he has done, I will declare an interest. I did used to work at Leeds Teaching Hospitals, and I did work with Julian in the communications team. But he has done a remarkable job in terms of running Leeds Teaching Hospitals, transformational work in terms of like staff engagement and really kind of steering the ship through an incredibly difficult time. So I feel it would be appropriate for this board just to pass on our thanks, and perhaps if we could, as a council, pass on our thanks to him for his service.
Absolutely, and I echo those words as well. Is that a nod from all of us? That's a yes, a huge thank you to him, and we're obviously infinitely grateful. Okay, so the next date of our next meeting is Tuesday, the 17th of January, 2023 at 1:30. So huge thank you again on behalf of the board, exec members, officers, the public, for bearing with us at, 3.5 hours every month is a long time to be in meetings, but we're truly grateful, and have a wonderful Christmas. If we don't see, make sure it's as joyful as it can be and stay warm. So take care, everyone. And thank you for all your contributions to all the board members. Truly, truly appreciated. Thank you.